source by changing position, but we were not able to do so because of a profuse bleeding. Meantime, patient heart rate went up to 150 per minute and his BP started falling. So OTSC was withdrawn. This illustration shows what might have happened, and there was an ongoing bleeding, but source was submerged in the pool of blood. We have asked surgeon and radiologist to get ready. However, we were afraid that he may succumb during transfer itself. Meantime, I got an idea of using endoscopic ultrasound to localize the source of bleeding, and specially mention you here that I wasn't happy as I see in this photo at that time. US was introduced. Lot of hyperechoic clots were seen within stomach, and I was able to localize a neuroendocrine tumor in the stomach, and while pushing scope I could see a large spurting vessel. The source of bleeding was localized. Here you can see a strong Doppler flow within a gastric lumen suggestive of ongoing bleeding. It was punctured with a 19 gauge needle and 1 ml glue was injected. Post glue injection, spurting was stopped. However, mild ooze was noted. So again, it was punctured with a 19 gauge needle and second cc glue injected. So this time I hypershooted the needle, and while withdrawing, glue was injected because it was very small vessel. So post glue injection, complete cessation of a Doppler flow was noted. Endoscope was changed for gastroscope, and now we could see the source of bleeding clearly. Additional half cc glue was injected with a gastroscope. Recheck endoscopy after half an hour showed complete cessation of bleeding. During procedure, ABC support was maintained and 2 PCV were actively infused with syringe. Noradrenaline infusion was started for hypotension and other supports were continued. Post-procedure, he developed pulmonary edema which was resolved after furosemide injection. He was monitored in ICU care setting, and there was no further bleeding and drop in hemoglobin noted during hospitalization. He was gradually weaned off from all the support and discharged in stable condition on day 4. To conclude, torrential bleeding during ESD of NET is rare. Majority of the bleeding can be effectively managed using conventional techniques, and US can be a valuable tool in cases of torrential bleeding where bleeding source cannot be readily visualized. US facilitate precise localization of bleeding source even within a pool of blood and guides therapeutic interventions. Thank you.
I think we should congratulate the heroic intervention. However, cath lab and immediate trans arterial embolization probably could have been easier and safer technique in this sort of a situation for people, especially also people need more US expertise to do this job.
Great Radhika, I have a question.
Great job. Radhika, sorry. Yeah, more continue.
Yes, okay. So, couple of things. Your first conclusion, which you said that bleeding during ESD for gastric nets is rare. I don't agree with that.
Okay.
Bleeding can occur, and my question is, did you do an US pre-procedure, pre-ESD? Because for NETs, it is one of the mandatory protocols to do an EUS along with other investigations to plan the procedure, because that it would have given you the vascularity. The other issue is about the ESD technique. Pre-coagulation is usually the way to go to prevent bleeding from occurring. You probably if you look at the video, the submucosal injection was probably a little bit suboptimal, and your initial incision was a little bit deep, because of which you hit that vessel. So, of course, later on the management was excellent.
Can I make a comment? When you see the pool of blood, what was the position of the patient?
Sir, patient was in a supine
so you could have changed the position and got it up.
No, sir, we did that, sir. We have changed the position, I have mentioned in a video also, but we were not able to do. Meantime, patient developed hypotension, he was developing various type of arrhythmia. We tried to...
But any previous CT scan was done before
CT
anything?
scan was done,
But we
sir.
did not see any images of
Yeah,
the scan
CT
here.
I have not provided.
But CT would have
And-
shown you, if you would have been CT, you would have seen that vessel which was there.
No, in CT they have mentioned only two small enhancing lesions, sir. They have not
Then
mentioned about
probably there was, as
Radhika,
Amol said,
One last comment, not a question. Very, very good job. You salvaged the situation beautifully. Anybody was checking your pulse rate and your BP during the procedure?
Sir, I just want to say I could have done an endosono before. That is actually limitation of my case report. I usually do, but I don't know, somehow in this case we have missed it.
And there's one final point I just
Yes,
want
sir.
to make, that a basic rule of glue injection is it should never be injected in arterial spurter. Glue is only for venous bleeding, because you can create embolization by directly putting in artery.
So that I accept, sir, but I don't know at that time what to use, because
Yeah, you
it
got
was-
away with it just now.
Sorry?
But you could have embolized. That glue could have gone in that artery if it had gone deeper and infected some other organs.
But I didn't have other option. Coils were too, that lesion was very small, sir, to inject the coil. And sorry.
Good job, and you should have presented how you got resuscitated. Good job.
I call upon the next presenter, Dr. Sahaj Rathi.
Endoscopic ultrasound guided portosplenic split for refractory hepatic encephalopathy. A 45-year-old male with ethanol-related cirrhosis who was referred to us because of recurrent hepatic encephalopathy for over a year. Despite being on optimal doses of rifaximin, lactulose and branched-chain amino acids, he had persistent astrolysis at presentation, severe slurring of speech, making the speech unintelligible on many occasions even to family members. He also had hepatic Parkinsonism and profuse facial dyskinesias. At presentation, the patient had thrombocytopenia, elevated bilirubin and elevated INR, which brought his MELD score to 23. The patient was advised to go for a liver transplant. However, that was not an option because of financial constraints. So this was the anatomy. There was a large shunt connecting the short gastric vein to the left renal vein. Occluding this shunt could have led to a reduction of portosystemic shunting, and all of the blood from the mesentery as well as the splenic circulation would have gone to the liver. However, the patient had a high MELD and a high bilirubin, so we expected that this much of an increased flow may lead to hepatic decompensation. We thought out of the box here and realized that if we occlude the splenic vein, this would lead to a portosplenic split. That is, all of the splenic outflow would now go into the left renal vein and not congest the liver, while the mesenteric circulation will still keep going into the liver and not cross over to the systemic side. So this seemed like a win-win to us. However, this was highly experimental, and after discussion of therapeutic options, the patient opted to go ahead with this therapy. So here we have the echoendoscope at the stomach cardia. We can see the splenoportal confluence with the splenic vein taken off from the portal vein over here, and right behind the neck of the pancreas we can see this velocity of approximately 20-25 centimeters per second. And here we can follow this splenic vein towards the splenic hilum, and we can see this large bend over here and going into the shunt. And now we are coming back towards the portal confluence. So we chose this site for the injection of coils. We punctured this with a 19 gauge needle and injected 3 20 mm embolization coils followed by undiluted cyanoacrylate glue 2 cc's. This led to formation of a coil glue conglomerate over here. However, we still saw a fair bit of flow going towards the splenic vein. It was lesser than before. It is now down to 15 to 20 centimeters per second, but still significant. So we again injected the coil glue conglomerate with another 2 ml of undiluted cyanoacrylate glue, and this did the job pretty well. And here we can see a large cast that is now seen in the splenic vein. And if we now go back to the portal venous end, we can see that the velocity of flow towards the splenic vein has now reduced to less than 10 centimeters per second. At this stage, we decided not to inject any more glue because these low velocities usually tend to thrombose on themselves. The patient did well post-procedure, barring mild abdominal discomfort for 1 day. That improved. Developed no ascites or no worsening of liver parameters and was discharged home on day 7. CT scan done a month later showed the presence of coils here in the splenic vein as expected with this cast in the splenic vein. we can see that the superior mesenteric vein is continuing into the portal vein without any extension of thrombus, and the splenic hilum is continuing into the splenorenal shunt. So we were able to achieve exactly what we expected to achieve here. Here we can again see that the splenic vein is completely occluded with coils, and we can see a glue cast over here in the corner and sagittal planes. Now this is the clinical improvement of the patient. The patient initially had asterixis and facial dyskinesias as are seen in the video. The video has been shared with consent of the patient. After a month, we can see that the asterixis is markedly improved, and we see barely any facial dyskinesias now. The patient reported a much improved quality of life. At 3 months, the patient reported no episodes of overt hepatic encephalopathy. The speech is now clear. There is no more slurring, and the family members can completely understand what the patient says. Asterixis is markedly reduced, and extrapyramidal manifestations have also reduced markedly. Another CT scan at 3 months showed that the portal vein, which was 6 millimeters to start with, had now expanded to 9 millimeters, likely consequent to increased flow from the mesenteric circulation. And here we can see the shunt that is still patent and continues to drain the spleen. Serial EEGs done at baseline 1 and 3 months showed a marked improvement, with the baseline EEG showing diffuse slowing of the brain waves with theta wave pattern, which at 3 months showed a marked increase in frequency, and an alpha wave pattern, which is consistent with the clinical improvement of the patient. So to conclude, refractory hepatic encephalopathy is a difficult situation to treat. Transplant may not be feasible for all patients. Shunt inclusion can definitely be the way to go for patients who have preserved liver reserves. However, in those who have poor liver reserves, the options may be further limited. These patients may benefit from EOS-guided portosplenic split. There is definitely a biological plausibility towards it. However, it will take further prospective data to establish its place in the clinical scenario.
Good job, and what an interventional radiologist used to usually do, you have demonstrated through EUS, and also, you have chosen to do the right thing for this patient.
Yeah, Sahaj, excellent presentation. My question is, what has happened to the blood flow to the liver? Has it increased or decreased?
So, sir, the blood flow to the liver has definitely increased because all of the mesenteric flow that was previously being shunted is now going towards the liver. As we saw, the portal vein was really small and thready to start with, and over 3 months the portal vein has expanded, but because all of the splenic flow is not coming in, the liver never got congested, so we never got that decompensation. So I mean, this was a very frail patient with a very, this was a very calculated decision. And
yeah. See, the portal pressure is directly related to two things, inflow and the resistance. So if you're increasing the inflow, are you not compromising and increasing the portal pressure, which is detrimental for the liver?
So you are absolutely right, sir. If we ever close a shunt, that is exactly what we get. But this patient, the main problem was the recurrent hepatic encephalopathy and hepatic Parkinsonism. We had to close off the shunt, but at the same time, we could not have dealt with that very high portal pressure. Choosing to block the splenic vein prevented the splenic outflow going into the portal vein. So while the pressure would have increased, it did not increase as much as it would in a shunt occlusion. In fact, we have very old data of splenic vein obliteration by interventional radiology. It's a very rare procedure, occasionally been done, where they've seen that once the splenic vein is embolized, the pressure increases only 2 to 3 millimeters of mercury, as opposed to shunt embolization where 8 to 10 to 12 millimeters of mercury is what the pressure rises. So we did have some precedent to it. It was not completely out of the blue. Yes.
Yeah, short of time, so sorry.
Sorry, sir.
One short comment. Excellent concept. Have you done any more patients? Have you taken ethical clearance for a study or something?
So
because there are so many questions here, as Dr. Anil has said. So what happens, how much is the glue that you can place safely, and what are the clinical results? We have only one patient, which is very exciting, but do you have any more data on this?
We have done it only for one patient. Okay. To have a patient who needs such a procedure cannot go for transplant is very rare. Okay. We do a lot of shunt obliterations, but this only one we have seen in the last 3-4 years.
So I call upon the last presenter. We have one more video, the first one. Dr. Bhushan will be presenting in place of Dr. Saurabh Mukherjee.
EUS-guided transrectal coiling and glue injection of small bowel ectopic varices in a patient with cirrhosis and ascites. 53-year-old female presented with hematochezia Since 10 days, she had a history of decompensated cirrhosis with ascites secondary to NASH. An upper GI endoscopy at an outside hospital revealed small esophageal varices. A CT abdomen with venogram showed presence of ectopic varices adjacent to a small bowel loop with rectum away from the varices. She was referred to our hospital for further management. On presentation, patient was in hypovolemic shock on vasopressors. She was noted to have anemia with a hemoglobin of 6.1 and thrombocytopenia with platelet count of 76,000. Colonoscopy was performed with terminal ileal intubation and showed fresh blood, but no source of bleeding was identified. Interventional radiology performed a venogram from systemic circulation with access via femoral vein. However, the ectopic varices could not be accessed. A portal vein access was not performed given the significant ascites and coagulopathy. Patient continued having bleeding, requiring multiple units of blood transfusion and vasopressors in ICU. Management options were discussed, including TIPS versus EUS guided coiling or glue injection versus surgical shunt. EUS was performed and revealed large amount of ascites. The ectopic varices were identified floating in the ascitic fluid. The feeder vessel can be seen here. Paracentesis was performed and 2 liters of ascitic fluid was removed. The next day, patient was again taken for the procedure. Ectopic varices in the small bowel can be clearly visualized. The varices measured 15 by 10 millimeters. A 19 gauge needle was advanced across the rectum through the ascites into the varices, and a 15 millimeter coil deployed successfully. Following coil deployment, normal saline followed by 3 cc of glue was injected, again followed by normal saline to flush the needle. The needle was then withdrawn successfully. On Doppler, the lack of flow can be visualized in the feeder vessel as well as the ectopic varices. Post-procedure, patient's bleeding stopped. Vasopressors gradually stopped in 24 hours. Patient was discharged in 2 days. In conclusion, ectopic variceal bleeding can be challenging to manage when site of bleeding is inaccessible via a transmural or a vascular approach. We describe a novel procedure with EUS guided transrectal coiling and glue injection of ectopic varices. This procedure demonstrates feasibility and safety of this technique despite presence of large amount of ascites. EUS can be used to access distant sites otherwise not accessible via a transmural or vascular approach.
Thank you.
Thank you. An outstanding job, for a very difficult location.
Yes.
My comment is on the normal saline that I think by mistake.
Yeah.
So whenever you use cyanoacrylate, it's always distilled water.
Distilled water.
Never should use normal saline.
Sure,
Just
sure.
for all
Yes,
the
sir, we always do
postgraduates.
distilled water.
Just
No, my basic objection is, you said because of ascites, interventional radiological intervention could not be done. So which are the routes which interventional radiologists take? They don't go transperitoneally.
Yeah.
It is transjugular or through the femoral.
Yeah.
So what was the difficulty in, with the ascites?
Yeah, yes. It's not exactly with the ascites, sir. It is because of the financial constraint. The patient was also not very, the procedures carrying quite expensive, and the patient was not willing for that. And secondary, the profile of the patient, the platelet count at that moment was 30,000, 40,000. That was also not
puncturing
not
the
very
bowel
much.
lumen and is riskier with thrombocytopenia than puncturing the vessel wall.
Yeah,
Maybe next time I am here, Anil.
Yes, sir.
Yeah, maybe next time you have a similar patient, you think tips can solve so many other problems? Thrombocytopenia, ascites, bleeding at multiple points rather than injecting at multiple points?
Agree, sir. Completely agree with you, sir.
Can I clarify a bit? Because of ascites, the transhepatic portal venous approach and going into the ectopic varices was thought of by a radiologist. So ascites was challenging for that. Tips was already explained to the patient, and that this was a patient who was very financially poor. In fact, we had to support the patient from foundation.
Thank you. Thank you, sir.
Thank you.
Thank you, presenters. Now we move on to the next session, which is the state-of-art lectures. For this, I would like to invite the chairpersons, Dr. Anil Arora, Dr. Mahesh Goenka, Dr. Ramesh Kumar, Dr. Sandeep Laktakia, and Dr. Shaukat Ali Zargar to please come on the stage.
So, since we are running about 8 minutes late, let me start with the first state-of-art lectures. And it's delivered by none other than Kenneth Binmoller. We all know him as the inventor for many various devices, and we heard him yesterday also on a great talk on innovations. So, Kenneth, it's a 15-minute talk, and since these are state-of-art lectures, there will be no question answers. The question answers can be done during the lunch hours.
Thank you very much. I have to really say I was so impressed and really enjoyed the video forum session. This is the future. And having our younger generation of budding endoscopists show what is possible in the future. I'd like to just take a look at how our specialty has evolved over the past decades. And I've titled this Back to the Future. This legendary thinker said, if you want to know the future, look at the past. And a more contemporary legendary thinker from Hollywood, Doc Brown, said, let's go back to the future. So if we look back at the historic indications for endoscopic therapy, they can be summarized with the 3 Ps. The first P, prevention. This is exemplified by polypectomy, what we do every day in our practice. Palliation, for example, stenting of an esophageal stricture. Some of us are called clogologists because this is a large part of the work that we do, clogology. And the third P is the prohibitive risk patients. These are the patients that the surgeon does not want to touch. So we get the leftovers. But in this new millennium, a paradigm shift has occurred from the historic lesser invasive alternatives to surgery that we provide to increasingly the primary treatment of choice. In other words, we have seen a transition from complementary to competitive. And this transition has been enabled by 3 procedural milestones. The first is endoscopic resection, second, the closure of defects and holes, and the third, EUS-guided therapy. We look at the evolution of endoscopic resection. It started with Shinya in 1973. He invented this snare. It evolved to EMR. Through submucosal injection, we could get a deeper level of resection and a more curative resection. With ESD, we switched out the snare for a dissecting knife, but this allowed us to resect in an en bloc fashion, larger lesions. And the most recent evolutionary development has been the pocket ESD, where we can actually insert the endoscope into the submucosal space. And so we have discovered a new space that we call the third space. So we have made this evolutionary shift from prevention in the early days to cure. Third space endoscopy. This is the buzzword, what we're all excited about. We can access this space, we can expand it, we can tunnel within it. It allows us to resect mucosal lesions with pocket ESD that you've seen in our live demonstrations, but also we can resect subepithelial lesions. We call this STIR. We can also go a level lower to the floor, and we can incise the muscularis propria, and we can perform the POEM procedure. And there are variants of this, the E-POEM for achalasia, the Z-POEM for Zenkers, the G-POEM for gastroparesis. But we can also go even a layer deeper into the second space, and this is notes. And this was first reported, this entry into the second space, by Inouye, great surgeon pioneer of this area, where he performed a POEM procedure and then a fundoplication to follow, something that you've seen many times and pioneered here in India. Now, this second procedural milestone is the closure of defects and holes. I contributed to this very early on, back in 1993, when I used clips to close a perforation after attempting resection of a gastric leiomyoma. This then evolved to the use of OTSC. I call these clamps. And then suturing. First, Paul Swain reporting this back in 2000 with the endocinch, but it really didn't become mainstream until the availability, commercialization of the overstitch device. But we can also plicate. So we can remodel the gastrointestinal tract. We're not resecting anything, we are just remodeling it. So this allows us to do the TIF procedure with various devices, or ESD, which you also saw in the live demonstration. Today we call this endoscopic gastric remodeling. The third milestone is EOS-guided therapy, saving the best, of course, for last. So EOS-guided therapy allows us to stay inside the GI lumen, and now we switch out our endoscopic eyes for our ultrasound eyes. So these are our new eyes that allow us to see structures outside of the gastrointestinal tract, organs, vessels, ducts, and pathology. More importantly, it allows us the ability to precisely target the pathology or these structures. So we have nerves, we can perform neurolysis, celiac blocks and neurolysis. Vessels, glucoil, you've seen beautiful examples of that. Tumors, we can perform chemo ablation and radiofrequency ablation. We can target ducts, we can pass a guide wire and perform a rendezvous procedure, and we can stent fluid collections. But I think the real excitement has been in our ability to create an anastomosis. Drainage is wonderful, but we can actually create an anastomosis or a port to extend the reach of the endoscope, and this is what LAMS has enabled. These are my first views of the inside of the gallbladder. I never knew what the inside of the gallbladder really looked like until in the pig lab I was able to visualize this thanks to using a LAMS as a port. So now we are making this evolutionary transition from unclogging the lumen, clogology, to bypassing. So now we're stepping into the surgeon's territory, a territory that they have, of course, dominated in the past, and we can bypass ducts, be it the bile duct, the cystic duct, or pancreatic duct. So we have hepaticogastrostomies, colodoco, duodenostomies, cholecystoenterostomies, and pancreaticogastrostomies. And we can perform enteric bypasses with gastroenterostomies and enteroenterostomies. You've seen beautiful examples of that today in our video forum. The LAMS provides a port for direct transluminal therapy. This is extending our reach into really that second space. So for a walled-off necrosis, we can perform necrosectomy. In the gallbladder, we can perform lithotripsy and stone extraction under endoscopic visualization. We can also perform polypectomy, and who knows, maybe in the future EMR and ESD in the gallbladder. And when we have a remnant stomach in a patient post-gastric bypass, well, we can access that remnant stomach and then perform interventional procedures. So back to the future, well, let's look at what Doc Brown saw. He was looking backwards, and if we look backwards, we look at 2004. This was the first report of notes by Anthony Kalu. Then it seemed like science fiction that we could use the GI tract as our port to enter into this second space. We developed a variety of triangulating platforms for notes. I had the opportunity to experiment with some of these platforms, but they all subsequently died out, and I think the reason is because we really couldn't close the holes that we had created, but we now can do that. So I think that as we look forward, we think of the wisdom of Abraham Lincoln. The best way to predict the future is to create it. And I can honestly say at this meeting this year, we are creating the future. Thank you very much.
Thank you, Kenneth. We have a couple of minutes. Can we have question and answers? Since Dr. Binmola finished before time, are there any comments, questions? Anybody from the chairpersons?
What is the future of third, I am Anil here. What is the future of third space endoscopy? After, you have accessed almost everything from esophagus down to the colon. So what do we envisage the future modalities?
Well, I'd say that we've pretty much conquered the third space. It's just amazing what we're able to do within this space. It's all a question of how far we want to take our tunneling. I think as we develop devices that we can implant into the third space, that opens all sorts of opportunities for therapy. One can certainly imagine that we can place sensors, for example, into this space. One can imagine that we can implant therapeutic devices of some sort. And it definitely has given us the confidence that by creating this tunnel, we can enter into that second space with relative immunity because we can close the opening to the tunnel. It really has been our fear that we will end up having to send our patient, and historically the patients that we treat have been the patients that have been high risk for surgery. In other words, those patients who can benefit the most from our procedures, those are the same patients who fare the worst if they have a complication. So we have been always cognizant of the potential that we can create a complication that we need to call the surgeon for to rescue us. So I think all of these recent developments have given us the ability now to do more aggressive treatments that we historically have been reticent to perform.
And what about the future of nodes? Is that the end of the tunnel for nodes?
No, actually, we will see an amazing revival of nodes, and you saw that in the video forum so beautifully today. Amit Madeo actually very appropriately pointed out that this is really a landmark in terms of our ability to now revitalize our interest in nodes and what nodes actually can do. It was always about really our inability to close that hole or our fear that we could have leakage. And so we can robustly close these openings. And it's also about the ability to enter these spaces very safely. I actually think that LAMS will also become an important component of the nodes revolution.
Kenneth, you talked about paradigm shift from complementary to competitive. From patient's perspective, when we are competing with one another, I think the patient sometimes feel that what is best for him is not being done.
This is also evolving. This competitive spirit is a thing of the past. Just as we have seen EUS and ERCP emerge, so endosonographers and ERCP enthusiasts are now becoming a hybrid. I think we're seeing this similar hybrid between the surgeon and the gastroenterologist. We are interventional endoscopists. It doesn't matter what your background is. So I think that the patient will also increasingly appreciate that surgeons now are recognizing that this is an important part of their training and their practice.
Vipul, you have a comment.
Ken, brilliant as usual. Major challenges in the world, we have obesity and metabolic issues. Are you working in that area? What do you see flexible endoscopy role there?
Yes, I didn't mention that, but I think this is another area that we're going to see amazing development. So what we're really seeing now is that we're going, far beyond the concept of clogology, just a mechanical treatment, but we're looking at the physiology. So we can, we're interfacing with the microbiome, we're interfacing with the physiology of the gastrointestinal tract. And so this is the treatment of metabolic disease, which is obviously a major pandemic that we're dealing with today. That is something that will be the focus of future developments. Thank you.
Thank you, Dr. Binmola. It was I am sure all of you would agree that it was a brilliant talk by the person who is the real innovator. May I next invite Professor Horst Neuhaus for his talk on ampullectomy. Have we perfected the techniques and minimized the complications? Dr. Horst, please.
Yeah, thank you very much for the kind introduction. Good morning, everybody. It's a pleasure for me again to participate in this outstanding conference and to talk about ampullectomy, having perfected the technique and minimized complications. So I would like to emphasize that there is a semantical issue. Ampullectomy can be only done by surgeons because this involves the muscularis propria, requiring reinsertion of the PD and CBD. So as endoscopists, we do papillectomy, not the ampullectomy. What are the current indications? Lesions in which the histology showed an adenoma, subepithelial tumors, and T1 and 0 adenocarcinoma with low risk factors in selected cases. So according to the endoscopic criteria, the size should have a diameter of not more than 5 centimeters, more for lateral spreading papillary adenomas. There shouldn't be signs of malignancy, so we evaluate if the lesion is movable, soft, and there is no ulceration. And the intraductal extension should not exceed 1 centimeter. The role of pre-interventional imaging shows that it's not really obligatory, but advantages for evaluation of the intraductal tumorous extension, in particular when you want to avoid ESCP before papillectomy, for exclusion of T2 stages in cases suspicious for cancer, and for identification of patients with pancreas devesum, because in these cases there is no need for a prophylactic pancreatic stent after papillectomy. So if the adenoma and so the subepithelial tumor is limited to the papilla, we should try an en bloc resection and not inject before the resection, because by definition the papilla is connected to the PD and CBD. You cannot lift it, but just snare it and resect it in an en bloc fashion. This is obviously here LST, a lateral spreading tumor involving the papilla, and here again it's not necessary to identify the papilla but we start with resection of the lateral spreading tumor as we do a non-ampullary duodenal adenoma. So injection first to have a safety cushion below the lesion, and then we snare it and do it in a piecemeal fashion. There is no need for en bloc resection because an adenoma is by definition limited to the mucosa and doesn't involve the submucosa. And this is quite similar to piecemeal EMR also in the colorectum. So here we harbor the specimen, and then we proceed in this piecemeal fashion, and we can always finally identify the site of the papilla after complete resection. And then it's important to try to cannulate the PD to place a pancreatic stent, because this will reduce the risk of post-ESCP pancreatitis. So we use a guide wire with a hydrophilic tip, advance it in the PD. And here we insert a biodegradable, fast degrading stent that needs no further follow-up. There are no randomized controlled trials comparing endoscopic papillectomy with ampullectomy, and therefore I refer to a systematic review of 29 uncontrolled trials involving 1,751 patients. And in terms of the efficacy, the procedure is very effective. Complete resection 94%, en bloc resection 76%, and curative resection could be achieved in 87%. However, you have to consider recurrences in 12% of the cases on average, but most of them can be endoscopically managed. We should consider that papillectomy is an advanced procedure and associated with a relatively high adverse event rates, on average 24%, mainly related to bleeding 11% and post-ESCP pancreatitis 11%. And this risk is obviously lower in case of stenting, so 6%, and no stenting 18%. And perforation is quite rare in 3%, cholangitis 2%. So it's an advanced procedure and can cause these complications. So if we compare FAP related with sporadic ampullary lesions, a recent propensity score matching involving 101 patients in both groups showed that the initial R0 rate is significantly higher in case of a sporadic ampullary lesion, 83% compared to 63%. Otherwise, there's no significant difference between both groups according to a multi-center trial from the Netherlands in terms of definitive complete resection, adverse events, and recurrence rate. So it can be done in FAP as well as in case of sporadic ampullary lesion. So recently, a hybrid resection technique was introduced. That means hot snare papillectomy followed by cold snare resection of the LST component, hoping to minimize the risk of delayed bleeding. And this is a comparative trial which was just published from the Sydney group from Michael Berg. They compared a prospective cohort with a historical cohort, 20 patients with hybrid resection, 56 conventional resection, and the results showed no significant difference in terms of intraprocedural or delayed bleeding, although it was higher in case of conventional resection. It was not powered for bleeding. Nevertheless, the drawback of the combined technique with cold snare resection is that the recurrence rate is 3.5 higher, 59% versus 30%. and more procedures are needed to treat recurrences. So it's not recommendable to compare hot papillectomy with cold snare resection of the lateral spreading part. So what about management of adverse events? This is obviously an intra-procedural bleeding right after en bloc papillectomy. And here, firstly, I try to tamponate the bleeding with submucosal injection. Now the bleeding temporarily stopped, and then I try to identify the PD orifice to place a PD stent. So I carefully probe with the tip of a sphincterotome. I could advance the wire, and you see bleeding restarted, and place a PD stent. And in this particular case, I also placed the biliary stent to ensure appropriate biliary drainage. And then you have several options, in particular using electrocoagulation, because you already protected the pancreas. So this is the coagrasper. Bleeding still continues, and we can also apply clips with no risk of blocking the pancreatic duct. Finally, the bleeding stopped, and to be on the safe side, I also used here hemostatic powder, the hemospray, to minimize the risk of re-bleeding. But this can be quite challenging. So intraductal tumor extension, I already mentioned it shouldn't exceed 1 centimeter. What we can try here after papillectomy to pull the intraductal part out of the papilla with a balloon, as shown here. So the tissue comes out of the papilla, and then we can snare it and resect it. Otherwise, radiofrequency ablation is a good option for intraductal tumor extension. International multi-center cohort trial, 29 patients were enrolled, and technical success rate quite high, 100%. Adverse events in 7 out of 29 cases. Strictures may develop, but the clinical success is quite high, 76%. This is a good option for cases with intraductal lesions. So recurrences can be seen, as I've mentioned, in about 12 to 15% of the cases. A recent multi-center cohort trial involving 154 patients showed a rate of 16% with patients who had at least 1 year follow-up. And interestingly, they have observed 53 patients with a more than 5 years follow-up, and recurrence occurred in 11% of the cases. So consider that recurrences can occur after a long follow-up period, and no risk factors for recurrences could be identified. How to manage? We dilate here the papillary orifice. You see the recurrent adenoma. We use here APC. We do also cholangioscopy to exclude the intraductal spread of the lesion. So I would like to conclude. Endoscopic resection of the papilla is minimally invasive and curative in over 85% of the cases. We have to consider high rate up to 25% of adverse events, even in tertiary referral centers. However, intraprocedural bleeding and perforation is usually manageable. Pancreatic stents reduce the risk of post-ESCP pancreatitis. Delayed adverse events, especially bleeding, are really emergencies with a significant morbidity. Recurrences seen in approximately 15% of cases, mostly endoscopically treatable, and long-term follow-up is strongly recommended, especially in FAP patients. And when you cannot wait for the next Endocon, and when you are interested in live cases, then you are kindly invited to attend our 27th Düsseldorf International Endoscopy Symposium in February. Thank you very much for kind attention.
Thank you, Professor Neuhaus, for simplifying the nuances of a difficult procedure, reminding us very well that even in tertiary centers, 1/4 of the patient may have adverse effects. I have two simple questions. Is the biopsy mandatory prior to ampulectomy? Number one. And at times, after doing a snare resection, it may be difficult to identify the pancreatic opening, and the more you try to fiddle around, the more it starts bleeding. So how do you handle that?
Yeah, so in terms of your first question, this is, if there is an obvious tumor, as I've shown in the video, then it's not necessary to take biopsies. When there is any suspicion of cancer, then I think we should take biopsies, because these are usually no candidates for endoscopic resection. And if there is a very small lesions, it's, I think, questionable, because when you take biopsies, you can also cause a pancreatitis. So for your second question, how to identify the pancreatic orifice? Yeah, is always the recommendation to use methylene blue, secretine stimulation, and you can try to do that. And I wouldn't spend too much time. If you cannot identify the pancreatic orifice, don't spend too much time. You may even increase the risk of pancreatitis. The evidence is not very strong that it's really advantageous.
Professor Neuhaus, what about the biliary stenting? You showed some cases in which you have done a biliary stenting, some cases you haven't. So what's your protocol for biliary stenting in these cases? And if you do stent, when do you remove it?
No, therefore I emphasized, I only used it in this particular case with bleeding.
Bleeding.
Otherwise, it's not necessary to use a biliary stent.
About the issue of the recurrence, is it related to the size of the initial lesion? Suppose you have a tumor which is 3 centimeters or has an extra ampullary extension. Is the recurrence more there or nothing to do with the size?
In case of this lateral spreading?
Yes.
Yeah, of course the recurrence risk is much higher. Yeah, and therefore you should try, when you do it in the piecemeal fashion, you should try to avoid leaving any bridges between the resected specimen. And you have to follow the patient, I would recommend latest at six months after the procedure.
The second point is that can we put a guide wire at the beginning in the pancreatic duct rather than fishing it at the end when it becomes very difficult?
Excuse me,
And my point is, suppose once we start the procedure, because we are always worried about the ampulectomy pancreatitis, can we first cannulate the pancreatic duct and keep a guide wire there and then they resect it?
Yeah, you can do that, but this makes it more complicated, because then you cannot really move the endoscope and so on. I think, so I wouldn't recommend that.
There is one recent publication.
As you have seen, when you have a complete resection, you can usually identify the pancreatic orifice. If you have a pancreatic stent first, then or a guide wire, then the resection is more difficult to achieve a complete resection.
There was recent one publication in which they had prophylactically put in a guide wire, and using a loop technique, they were able to complete the resection and then finally able to put in the stent.
Okay, you can consider that.
Yeah, one question from.
Yes.
Yeah.
Thank you. The concept of papillectomy was our suggestion, that the difference between papillectomy and ampulectomy, you are using that concept during this talk. Thank you. But my question is, before ampulectomy, biopsy shows adenomatous tissue, low grade, but after ampulectomy, the specimen shows focal cancerous area. Then what is your approach for those cases?
The patient should be, of course, presented in an interdisciplinary tumor board, and then it depends. If you have achieved a zero resection, complete resection of the cancer with just minimal invasion of the submucosa, well differentiated, and in particular, if this is a high-risk patient for surgery, then I think we can just follow, wait and see. There are some studies showing good outcome in these patients instead of doing a Whipple resection, because ampullectomy, surgical ampullectomy, has no impact on the oncological perspective, because then if you once you decide for surgery, then whip resection has to be done with lymphadenectomy.
Thank you very much. I think it was an excellent talk. Our next state-of-art lecture is being delivered by Dr. Dong Van Anthony. Dr. Anthony To, the topic is endoscopy for gastric outlet obstruction. Is gastrojejunostomy the way to go? Thank you.
So thank you for your kind introduction. So it's my great honor to be back here in India again and to be speaking after both Ken as well as Horst Neuhaus. It's my great honor. So today I'll be talking about endoscopic therapy for gastric airway obstruction. Is endoscopic GJ the way to go? So I think in the last few days throughout the live session we have seen many of these procedures, and duodenal stenting for palliation of gastric airway obstruction as well as US gastroenterostomy. So both of these techniques are endoscopic methods, and these are options, alternatives to surgical bypass in patients with gastric airway obstruction. As we know, USGE has some advantages. In particular, it combines the best of both worlds in terms of a improved stent patency, in which the USGE, the stent is placed away from the tumor, and also being an endoscopic procedure, so we do not need to have a wound to the patient, and also the patient recovery will be much quicker. But of course, the technique requires special expertise, and like the case yesterday, if there is a misdeployment, there is a risk of severe complication. And of course, the cost of stent is still a major hurdle in those countries with a lower social status. As we see this technique develop more and more, it's becoming apparent there are two main ways to perform this procedure. One is device assisted. In the past, you only have one device, which is the Toei Sensei's device, the EPAS device. But with time, we are seeing newer devices, like the through-the-scope balloon device from Yen Chen from Canada, and also from India, your own country. We are seeing a double balloon device. So I call this the Cochin balloon. In the West, in Europe, they are mainly performing this procedure with the freehand technique, the water irrigation technique. And I think in India, in some places where you don't have the double balloon device, the water irrigation technique is still being performed. This is the double balloon occluder, through the scope double balloon occluder invented by Yen Chen. The special feature of this catheter is that the tip is removable. So once we inflate the two balloons, we can withdraw the scope, detach the tip of the catheter, remove the scope, and then reattach the catheter to instill saline between the two balloons. So I think in AIG, they also have some experience with this procedure. This first part is still to cannulate the stricture, insert the guide wire deeply, and then you see the through the scope balloon being inserted with two balloons here. The balloons are inflated with air up to 4 centimeters, right here, inflating the balloon with air. And then the scope is being removed. So you can see me removing my scope. And here is the tip of the catheter, which could be removed. And now you can see the tip reattaching on guide wire. And then at the catheter, the reattachment is very easy. So just attach it here. No need alignment, and then it's usable right away. So if the balloon is slightly deflated, we can reinflate again, followed by injection of the Endocon solution, a very nicely distended little vial, right there. Very largely distended, and in this case we use the hot spaxes. So not the hot axials, but the hot spaxes. So they still have a very good luminal pulsing force, and because we are using the double balloon technique, we can really take our time to perform this procedure. So this is the spaxes. So I'm also very excited to see from India the Cochin double balloon, so from Dr. Zakaria. So a very similar kind of device. This is not detachable tip. So it's inserted on guide wire. So the two balloons are inflated with air again. You can inject saline in between the balloons. And the good thing about this balloon is that after cannulation, you withdraw the scope, and the catheter can be inserted on guide wire. It's very stiff, so you don't need a over tube, and then it can be just inserted by itself all the way beyond the stricture and inflate the two balloons and perform EUS gastroenterostomy as per usual. With initial studies, we saw that ESGE has many advantages. In 3 studies comparing to duodenal stent lab GJ, USGE was associated with better clinical success, less adverse events rate, and less re-interventions. In our study comparing EPAS versus GJ versus duodenal stent, procedural time was less than GJ, hospital stay was lowest in the ESGE group, recurrent obstruction is less, re-intervention is least, GO score, meaning the oral diet that the patient tolerated, was the best. And this was confirmed in the meta-analysis. And in this year, we published our study in Lancet Gastro. So comparing the USGE with duodenal stent, procedural time was slightly more, but in terms of re-intervention, significantly less, 4.2% versus 28.6%. Stent patency was significantly more, and very important is the GO score. More patients could tolerate an oral diet, even rice, curry, and they can have much better functional outcome. In terms of stent patency, we see a very nice improvement in stent patency, favoring GJ, ESGJ. So we concluded that EPAS significantly improved the stent patency and eating functions in patients suffering from malignant GOO, and this should be the procedure of choice when expertise is available. And currently, the procedure is also recommended by ESGE as an alternative to duodenal stent or surgery. In terms of the size, this study compared 20 millimeter versus 15. If you had 20 millimeter, definitely better outcomes in terms of being able to have a complete diet. And of course, adverse events, stent misdeployment is the worst feared condition, but actually, most of the time with misdeployment, we can salvage endoscopically. There are 4 types of misdeployment, 1, 2, 3, 4. Type 1 and 2, most of the time you can salvage endoscopically. So if there is a misdeployed distal flange, you can just remove the whole device, reinflate the small bowel, and then try to perform the GJ or duodenal stent. For type 4, it sounds horrible, it's a gastrocolic anastomosis. But even if this happens, you can leave the stent for 2 weeks and then come back 2 weeks later, remove the stent, close the gastric opening, and the fistula will close by itself. For type 3, it's a bit more difficult. The proximal flange is misdeployed, and you may need to do a stent-in-stent deployment to salvage or to do a nodes procedure to try to fish out the misdeployed proximal flange. Of course, there are a few questions that needs to be answered. Cost effectiveness. So the main cost of the procedure is still the stent. Only if we see a significant reduced amount in the cost of the stent, I think this procedure will become more and more popular. And also, how about very frail patients? So if the patient has a very limited life expectancy, very frail, bedridden patient, well, I don't see the problem of performing a duodenal stent in these patients because it's a safe, cheap, very quick procedure, and probably in these patients, they would not last very long, and even inserting a duodenal stent would be sufficient for these patients. So in conclusion, US guided gastroenterostomy provides significantly better outcome as compared to duodenal stent and surgical GJ in malignant GOO. The optimal technique is still in evolution, but I think USGE should be the preferred technique, provided that the technical expertise is available and patient has a good life expectancy. So thank you.
Thank you, Professor Anthony. Excellent presentation on a new innovative technique. My question is, compared to duodenal stenting or enteral stenting, what are the advantages? Because duodenal stenting is so easy, it's available with everybody, you just need a fluoroscopy. What are the different advantages? If it gets blocked, you can put in another overlapping stent. Can same thing be done with USGJ?
Yeah, so as shown in my study, the advantage are several. One is reducing reintervention. Hospital stay was shorter, and the quality of eating is actually much better. They could tolerate solid diet, and so I think the quality of life would be better for these patients.
But how can the hospital stay be longer in duodenal stent? Because it can be done on OPD basis. Why it should be 5 days in your study versus 1.2 days in USGJ? I thought that is easier to discharge.
Some patients, they actually have a quite, after the duodenal stent, they have quite early need for reintervention. So even if we insert a uncovered stent, sometimes the tumor will be coming out from the stent and you suffer from a very early reobstruction. So the intervention rate is quite high, up to 30%. So that's probably why.
And moreover, if you look at the side effect profile also, missed deployment and incidental colonic puncture, so those will be practically absent. Any young upcoming gastroenterologist can put in a...
Yeah, of course. So that is our conclusion. So you need to have the expertise. And then you need to have a very safe system. So in our study, we use the double balloon, which is a very safe system. So if you use the water infusion technique, of course, you need to have an expert. You need to work very fast. So I agree.
In terms of cost and also the reinterventions, how do you compare it with the duodenal stenting?
So I think the interesting fact would be when you have reintervention, it's an additional cost. So whether this cost can be overcome by GJ. So for the GJ, the main cost is the stent. So if you have reintervention, you also have a cost. So whether the cost of the stent can be overwhelmed by the reintervention, that'd be a good question. But I think with more and more LAMs coming out, the cost of LAMs should come down.
And the second issue is that we know that some of these patients are stable. They have a good performance score. And we know with the duodenal stenting also there are a lot of interventions are required. Why don't we put them for a laparoscopic palliative procedure rather than having more follow-up, more interventions? It's a one-time procedure.
Yeah. So lab GJ certainly is a possibility. So actually I'm a surgeon, so in patients, sometimes we are not sure whether they are resectable or not. We do a staging laparoscopy and we see peritoneal mat and we will do a lab GJ at the same time. But some patients, they come in with metastasis, although they have a good functional status. So maybe in those patients, we will perform a USGJ. So different patient population.
Okay, yeah.
Sir, in a patient of gastric outlet obstruction in which duodenal stent is already in situ, is blocked, then there are two options. If patient is surgically unfit, that's okay. But surgeons are not happy with USGJ. There are very two arguments in the favor of surgery, lab GJ. One, the stoma which they make it is very, very wide. Here we can make only 20 mm stoma. Number two, they believe that they can make that stoma in dependent portion. Here we want to access, but we are not sure from where we are making that stoma, which part of the stomach.
Actually, we are pretty sure where we are making the stoma. Most of the time it's in the posterior stomach. And then we are actually going through the transverse mesocolon to the DJ flexure. So this is a dependent portion of the...
And size, this is the...
30 millimeters.
I think we will have to wind up. Thank you, Professor Antony,
Thank you.
for an excellent presentation. Now we come to the last talk of state-of-the-art lectures. This will be delivered by Dr. Dong Wen Su, and the topic is going to talk about is endoscopic therapeutics in pancreatic neoplasm. Dr. Dong, please.
Thank you. It's my real pleasure to join this wonderful meeting. It's my eye-opening meeting. It's very great. Endoscopic therapeutics in pancreatic neoplasm. There are many different methods of treatment of pancreatic tumor under US guidance. But among these, what I am experienced are these three areas. So I'm going to talk about these, cover these three topics based on my personal experience. The first one was ethanol injection for pancreatic solid tumor. This is 99-year-old male patient admitted because of recurrent hypoglycemic attack. And during hypoglycemia, insulin and C-peptide was highly elevated, so the presence of insulinoma was highly suspected, but CT scan did not show any lesion. But EUS can catch about 1 cm size hypoechoing mass. So this was the culprit lesion, biopsy confirmed, but the problem is what kind of treatment should we offer in this case? This is almost 100-year-old patient. Surgical resection is not the option. So we decided to do US-guided ethanol injection on this case. Now we are using 22-gauge needle for the injection of ethanol. The bottom half is already treated. We are targeting the upper half of the insulinoma, and we are injecting 0.2 to 0.4 cm, 4 milliliter ethanol into the tumor, into various areas of the tumor. So the total volume of injection was 1.5 cc ethanol. And after this, we checked the contrast enhanced EUS. Then before therapy, there was high contrast enhancement, but after therapy, you can see contrast void area, confirming that this lesion was ablated effectively. After this, the patient never had any attack of hypoglycemia. So if you use this technique in selected group of patients, it can be very helpful for the patient. This technique can be used in small benign tumors, insulinoma, neuroendocrine tumor, or SPM. But there are some issues. The method of injection of ethanol is not standardized, and the amount of ethanol is not calculated scientifically, more like the empirical based therapy. And frequently, remnant viable tumor is an issue. Now I'm going to move on US-guided RFA for solid or cystic tumor of the pancreas. Our group was interested in this technique, so we did collaboration research with one of our Korean companies, Samed company, which produces RFA probe. So we conducted ex vivo and in vivo animal study and started human clinical trial. And this is one of the cases. This is 43-year-old male patient suffering from MEN1. So before, this patient received multiple operations due to multiple tumors. Now, at the resection margin of the pancreas, there is another neuroendocrine tumor development. The patient refused animal surgery. So we decided to target this lesion under US guidance by RFA probe. The probe is 19-gauge RFA probe, 1 cm electrode part, and we punctured the tumor deeper part first, and the right side on the screen is the first target. And during this period, we used 50 watts power until echogenic cloud formation. One spot ablation, and then we retracted the needle into the superficial part and covered the superficial area. This is one line of ablation. After this, we changed the direction of the needle and covered the different direction until the full coverage of the tumor. After this, when we checked CT scan, there was necrotic area development in the tumor area, and 9 months later, the tumor became rudimentary. So we reported these results in Endoscopy 2018. We collected 10 patients with benign solid pancreatic tumor, including insulinoma, neuroendocrine tumor, and SPM. Among them, 70% of the patients showed complete resolution. So our conclusion was RFA is safe and potentially effective treatment option for this type of small benign pancreatic tumor. Other groups also reported RFA results for cystic tumors and solid tumors. If you look at this meta-analysis, the technical success rates for pancreatic solid or cystic tumors, the technical success rate is almost 100%. Clinical success rate is about 90%, but it is based only on expert centers. And the adverse event rate is about 15%, 10 to 20%. These are the list of potential complications related to EUS-guided RFA, and pancreatitis, MPD stricture perforation, and bleeding. So we need to be very careful when you apply this technique to pancreatic tumor. Our group was also interested in pancreatic cancer treatment, but resectable pancreatic cancer, we think still the surgical resection is the best option. But unresectable, but non-metastatic, locally advanced pancreatic cancer, we are doing chemotherapy, but we thought about what about if we combine RFA and chemotherapy. So in this case, we can see the tumor infiltrating into SMV and the portal confluence, locally advanced one. So during the treatment, we combined RFA and chemo. And after several sessions of RFA and chemo, we can see marked volume decrease of this tumor. So we conducted this single-arm study, included about 22 patients with unresectable locally advanced pancreatic cancer, and the combined treatment. If you look at the survival, 1 year is 71, 2 years was 56, median survival was more than 2 years. We thought it is a little bit encouraging results, so we are nowadays conducting prospective randomized controlled trial comparing chemo alone versus EUS-guided RFA plus chemotherapy. We will see the results. Last topic is EUS-guided ethanol lavage plus minus Taxol injection. If there is any growing cystic tumor in the pancreas, we can delineate the lesion under EUS guidance. We can insert echo endoscope into the stoma or sometimes into the duodenum and can delineate the tumor. And we can use 22 gauge needle or 19 gauge FNA needle to aspirate the cystic fluid and inject ethanol. We can repeat this 3 or 4 times. This is called ethanol lavage. And if necessary, we can instillate finally a small amount of paclitaxel inside the cystic tumor. This is one of the case, 26-year-old female patient showing about 4.5 cm cystic tumor in the body. And when we did EUS, there was some echogenic debris inside the tumor and the mural nodule-like lesion in the cystic cavity. We used the 19 gauge needle and aspirated the cystic fluid. During aspiration, we touched the echogenic area, but it is fragmented and the shape changed. So we confirmed that this is not true mural nodule, more like a Newton plug. So we aspirated the cystic fluid and did the ethanol lavage. This is the color of aspirate and ethanol injection and re-aspirate. And the total 4 times of ethanol lavage was done. And as you can see here, 6 months later, the cystic tumor was completely disappeared. We reported this ethanol lavage plus or minus paclitaxel injection as a new technology for cystic tumor treatment in GIE 2008 and also gastroenterology 2011. And 2017, we analyzed the long-term outcome data. And when we analyzed 164 included patients, complete resolution was 72% and the partial resolution 20%, and the persistent cyst was observed in 8.2%. Once CR was achieved, we checked the recurrence rate up to 10 years, but the recur rate was 1.7%. It is quite durable type of treatment. But later, we observed more recurrence than this. And last year, we compared the long-term outcome data between ethanol ablation versus surgical resection for pancreatic cystic tumor. We tried to compare long-term outcomes and also safety. But naturally, surgical resection group generally has larger cysts and more aggressive cysts and more malignant looking like cysts. So it's not fair to compare directly, so we use the propensity score matching. So the size of the tumor, location of the tumor, and the presence of septa mural nodule was the same group. When we compare long-term morbidity, there was striking difference between surgery and EUS-guided ethanol ablation. And the effect-wise, CR rate was a little less in EUS-guided ablation, and the relapse rate was 5%. But surgery group, CR rate was 100%. But there is a lot of complications. Until 6 months, post-operative fistula or pseudocyst infectious complication. Until 2 years, diabetes development. Until 4 years, incisional hernia, anastomotic stricture, obstructive pancreatitis, cholangitis. Even after 5 years, there is stone formation, biliary cirrhosis, and gastric varix, A-loop syndrome, mechanical ileus. So when we decide the therapeutic strategy, we need to think about these long-term outcomes too. This is one photo showing the result of surgery. At the time of head resection, we can appreciate pretty large amount of pancreatic tissue in the left side, but 18 years later, there is no discernible pancreatic parenchyma, only dilated pancreatic duct. Surgery is a good treatment, but not without price. So when we decide the treatment strategy, we need to think about this. This is my final slide. US-guided therapy of pancreatic neoplasm can be done by ethanol injection for benign solid tumor, or RFA for benign or malignant tumor, or ethanol injection, lavage, Taxol injection for cystic tumors of the pancreas. If you select appropriate patient and do the procedure responsibly, then it can be safe and effective treatment. Thank you very much for your kind attention.
Thank you, Professor Dong, for giving us the absolutely new dimension of further extension of therapeutic EUS. So what was the cause of these pancreatic cysts which were ablated with RFA or ethanol lavage? Were they mucinous or serous adenoma and they were not fit for surgery, or you did a comparative trial?
During initial study period, because if you want to know a definitive histology, we need to do biopsy. But biopsy was not possible, but these days we can use EUS guided through the needle microposite biopsy, but on this case we did not do. CA level was very low and the amyloid was about 475. We don't know, we call this group as indeterminate group. If the CA is very high and the amyloid is very high, we can call this as mucinous and IPMN group. But in this case, it is not clear.
I think it was very exciting and stimulating talk. But first I would like to know, these patients who had a malignancy, they were all inoperable?
If the patients have clear malignancy, we do not do this type of procedure. We send the patients to surgery.
Okay, so they were basically inoperable patients who underwent this injection, Taxol
yes,
or
inoperable condition, or the patient who refused surgery, then we can include it. But even in those cases, we try to remove the malignancy.
Okay.
We don't think we can treat malignancy with this method.
Now there's a point that did it change these injections, the basic biology of the tumor? Did you use also combination of chemotherapy in these patients, or just only this much?
Excuse me?
What you said, you put a US guided injection of Taxol,
yes,
or you use a RFA. My point is, did it change the biology of the tumor as such in the long-term follow-up? And second point also, did you also use systemic chemotherapy in these patients?
Taxol is, yes, systemic chemotherapeutic agent, and we did some research using this material even for the normal biliary epithelial cells. We know that it can create a apoptotic reaction in the normal cells also. So we are using this concept for the treatment of cystic lining epithelium. And yes, it can change the course of, I think that's what we are expecting, but we don't have clear evidence showing that Taxol injection can change the biologic behavior of the cystic tumor.
Yeah, last question, please.
We are 10 minutes behind the schedule. I think we can take the
All
questions
right,
later on.
sorry. So my question is, what's your patient selection criteria for performing RFA for pancreatic neuroendocrine tumors? Is it only for symptomatic patients, or is there a size limit of the lesion, or when do you do it as compared to sending the patient to surgery?
I think that's a very good question. For neuroendocrine tumor, you mean? If you confine to neuroendocrine tumor, generally when neuroendocrine tumor is suspected, we do FNB and we check the grade of the neuroendocrine tumor. Generally, grade-wise, grade 1 or 2 are indication of RFA, and the size-wise, we are targeting less than 2 cm. If the size is bigger than that, it's difficult to homogeneously ablate all the tumor cells. There are patch area of remaining viable tumor cells, so generally for small lesions, yes.
Also for asymptomatic lesions?
Asymptomatic, yeah, maybe asymptomatic. If it is like a functioning neuroendocrine tumor, we can target it. Even though it is asymptomatic, the patient knows there is tumor in the pancreas, the anxiety increases a lot, then in those cases we treat the tumor by RFA.
Thank you so much.
Thank you. All of you would agree that we had a brilliant presentation by Professor Wong. Let's give him a loud round of applause. Thank you so much. And with that, we wind up today's presentation of State of Art lectures.
Thank you, chairpersons. May I invite the next set of chairpersons for the live transmission?
Am I audible in the hall?
Samir Mohindra.
Am I audible in the hall?
Bhagat, Dr. Rupesh Pokharna, Dr. Manish Gupta, Dr. Pradeep Kumar Sethi. And the moderators of the next session are Dr. Pankaj Tyagi, Dr. S.M. Manjunath, Dr. B.S. Ravindra, Dr. Sabir Hussain.
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
Sir, you are not audible.
You are not audible.
Am I audible now?
Yeah,
Yes.
better.
Yeah, good morning everyone. Welcome to Medanta the Medicity Endoscopic Live. Just to give you a brief update about the yesterday case, Dr. Nagi did the laser lithotripsy, patient is fine. FDRD by Professor Nihos, his patient is fine. Sandeep Laktiakar did the EUSGJ, is perfectly fine. Amol did the marathon ESD of 3.5 hours and complete specimen was removed. Poem done by Mohan is absolutely fine. Sigmoid leiomyoma, the new loop applied by Professor Bin Melo, his patient is perfectly fine. EUS pancreaticogastrostomy done by Nila is also good. Ileal stricture dilatation by Vadva is fine. Coil and glue by Bin Muller is fine. Just to give an important update, because yesterday I spent a lot of time on the patient, which I did. And just to tell you about this patient, because EUSGJ done by me. And this is the CT I'm sure you people are seeing. And you can see there is no leakage of contrast. There is no free air in the peritoneum. There is a mild fluid perihepatic, otherwise very small amount of fluid. We have done 3 CT scan consecutively on table after 2 hours and in morning. Patient is hemodynamically stable, no inotropic support. Patient is conscious, no pain abdomen with the God grace, and the CT scan is normal. Surgeons has seen, IR interventional radiologist has seen. IR say no need to aspirate. Surgeon says hold surgery because no abdominal sign and patient pass motion. I presume another 2 days should be fine with the patients. The most important thing is don't lose cool. The savior was keeping a wire in the peritoneum. That make me visible stomach hole, and CT scan done both from the gastric port and jejunal port, no leakage of the contrast. So thank you for that. And I would like to introduce the hero of this conference, Dr. Pawan, who is an anesthesia doctor, who made this conference possible, who made all the 4 rooms possible, doing the general anesthesia or so. One message which is important for gastroenterologists, which I want to ask, Dr. Pawan, what do you expect from the endoscopist to know, which is useful for you to give a better anesthesia care to the patient?
I'm audible?
Yeah, you are.
Thank you, Puri sir, and thank you. I feel privileged and thank you for your support, sir. And as an anesthetist, I would like one thing you should at least provide intraoperative details and intra-procedure detail before the procedure. So and any anticipating complication that going to happen, and so we can manage it and we can avoid, like you are going to do coiling, cystogastroscopy, and sometimes you are going to do poem. That time the chance of aspiration and patient get complicated. And if you provide proper information about the patient, this will improve the patient safety and patient outcome. Thank you.
So thank you, Dr. Pawan. And with that, without delaying the process, we start with our live. And I request Dr. Jubin to start with Dr. Sandeep Laktakia case. I think we start that
Yes.
case.
So
Thank you.
thank you today, and good morning again.
Thank you.
I start with the first case, a 42-year-old male with CAD post-PTCA. He had an acute traumatic pancreatitis, which was managed with multiple PCDs last year. But now he has a single PCD which showing a persistent drainage of amylase-rich fluid. On the CT and on the MR, there's disruption. It's a case of a DPDS. The plan is for an EUS-guided internalization or a tracheogastroscopy. So over to you, sir, in room 2.
Hi. Good morning, everybody. At the outset, I would like to thank Endocon, SGI, and Medanta the Medicity for hosting us here. We are in the other suite and we are about to start a case. Before I start, let me introduce my team. I have Nikhil Santhalia, and with Nikhil around, I am quite confident that we will be able to succeed. And we have a most important person, Nishant, here, who's the anesthesia chief in this room. So we just heard the other story. I think each room, we work as a team together, and the other parts of the team is Srinivas and Bipin. So you heard the story. This patient had traumatic pancreatitis about 5 months back. He had a drainage that time, and external drain also was kept, which is draining about 100 ml of high amylase fluid. So this is an external pancreatic fistula with a tube in situ, which has been there at least more than 4 months now. So before we go further, if you can see the X-ray there on the screen, can you have the X-ray there?
Yes, sir.
The patient is lying prone, sedated, not intubated. and the tube is on the left of the patient. You can see a big tube. My EUS scope is also there. And now we can go to the EUS image. You have the EUS image there?
Sandeep, previous ERCP is a disconnected duct.
So we don't have that information. MRCP shows that there was a disconnected type appearance, but that MRCP is about 2 months old. A recent CT shows a good pancreas in the head up to distal body, but the tail area looks to be disconnected, appears to be, I'm not very sure. So there are several ways of approaching these kind of a patients, which are a common problem that we all face. Whenever such patients go for surgery, surgeons place a catheter, and this catheter keeps draining fluid. So they will come to gastroenterologists. Surgeons have done their job and they said they've cured the patient. But the problem is this external pancreatic fistula, which has been found in Lancet trial also, where the major problem in the step-up approach versus endoscopy and surgery was external pancreatic fistula, which was a nuisance and affecting the quality of life of these patients. So our aim is to internalize this drainage, remove this catheter if possible in few days' time. We can approach, as Ravindra rightly said, that we can try an ERCP first.
Yeah, I think first we should do an ERCP and then show it, and then if that is a disconnected duct, then better to do a pancreatic.
There are several ways of approaching this problem, and that's one of the ways. I don't discourage that. The downside of ERCP first is sometimes you can actually cause a pancreatitis infection. And so let's do let's come transmurally and see. If you have a good MRCP, that's good. So you have the EUS image there. You can see the pancreas quite nicely. I am in the distal body region. You can see the aorta behind, and you can use the arrow and show. Yeah. So I'll request Nikhil to show the arrow. This is a pancreas parenchyma. Looks quite reasonably well. If I turn clockwise and go, and you see that Nikhil is pointing to the tube. This is the external catheter, which is casting a dense shadow. Upstream to that, we can see the pancreatic duct, which we measured before. It is 2.1. And there is substantial amount of pancreas still there in spite of, so he has a good pancreas volume still intact, and upstream pancreas is draining through this percutaneous catheter externally and is draining this juice there, which means there has to be a disconnected duct. If it was connected, then the likelihood of draining in the natural physiological way was much more likely. However, if the big tube is there and that's the path of least resistance, juice can follow. So I will now like to use the EUS method first, having placed the EUS scope. So there are two options of EUS intervention in this patient. One is to, if it's complete disconnected and the duct was little prominent, I would have first tried an EUS guided PD, pancreatogastrostomy, but the duct is so thin that the likelihood of succeeding is very low. Other option is to target this radio-opaque shadow, which is a tube. If you see the EUS fluoroscopy now, the tip of the scope is very close to the tip of this catheter. You agree?
Yes. Yeah.
Okay. So what we will do is we will puncture this area, targeting the tube as a target sign, a target organ, and put some contrast there. Some of the contrast will fill that potential area, which you have some kind of fluid around. If you see, let me move around this tube. So this area, which is little edema there, this is all the area where the fluid, so this is my target area, I would say, which is very close to the tube. Some of the fluid will go into the external catheter, majority of the fluid. Some may fill the pancreatic duct upstream. We will see how it goes. So let's cut the needle now. So I'll use a 19 gauge needle, which is the stylet has been removed and it is primed with dilute contrast. I'm using the Olympus ME3 needle. Easy shot 3 needle. Sorry.
Any advantage of clamping the PCD a day prior?
Wonderful. That's a very good point and a very valid point. What happens, you're suggesting is if you clamp this tube, nothing will come out. It will form a fluid collection inside, and that becomes our target and drainage. It's like draining a pseudocyst with a plastic stent. That's another option, yes. But now we have,
I think first
this is what we are in now. So we don't have the clamping point. We can't go back in time and clamp it. What we will do, if you're not able to enter this cavity, is inject some saline gradually, small amounts of 5 or 10 ml to get a little bit of target. If we can create an artificial type of not a pure pseudocyst, it will be a diffuse collection because it doesn't form a wall. we can still target that as a target for internal drainage. Does it answer your question?
Yeah, I think right.
So in our experience, when we have done this clamping 24 to 48 hours before, depending on the volume coming out, if somebody is draining 200 ml, I think just clamping for 6 to 8 hours is good enough. But if somebody is draining only 25 to 30 ml, I think we have to wait 2-3 days. In some of those cases, a collection would form, not in all. In those who form a pseudocyst, yes, that becomes a very easy target and becomes a conventional EUS guided cyst gastrostomy. But those who do not form, it becomes very fuzzy, then we are back to square one.
Because we don't have a wall, we cannot form pseudocyst.
Yes.
How many days after the initial catheter placement you do this type of procedure? Like we put a catheter and after 6 months or 3 months?
No, I don't think we should wait for very long. I think after 1 month time, patient is not improving, the fluid output is not decreasing, I think that's the time to intervene. If you ask surgeons to intervene, they will chop off the rest of the pancreas, which we don't want. We want organ preservation. We want pancreas to work as it was, salvage the upstream pancreas.
This patient has a 32 French catheter, which can
it's a very big catheter also. It's a big catheter, which also irritates the pancreas there. And this, you can see the tube. So that's my target, this area. Can you have the Doppler on, please? I will intermittently shut myself and request Nikhil to speak when I'm concentrating on the case. Please pardon me for that. You can remove the Doppler. This is too bright. I think what we'll do is Doppler with a very low flow. That's okay. This is okay. Now you can switch it off. There's no fluid. You can please take the question in case they come while I'm doing it. Thank you. Floor on? Yeah. Okay, now contrast, Srinu?
Contrast.
So you can see the needle is very close to the tip of the catheter.
And
the catheter is open, it's going into it only. Okay.
Can you open?
Yeah, it's open, it's already going into. So that confirms that I am in the right place. So my aim would now to push a little more saline and contrast there. I'll pull back a little bit. Stop. Okay.
You can see the contrast.
So you pass a wire. And if the wire goes into this catheter, that's even better. Then we have an external control as well, which is likely to happen. The way the fluid went in.
Then we will have internal, external drainage.
Yeah, then we can hold the wire externally also. The problem comes when this tube is far away from the EUS target, in the EUS view.
This is actually a perfect puncture done by sir. We're using a VisiGlide wire, right?
This is Termo?
Termo.
Okay. Termo can slide in the tube. Okay, wire hai? Okay, wire has come. It's going in the tube. It's going in the tube. Push. It's gone in the tube only. Wonderful. That's what I wanted.
Superb.
And that's gone. Wonderful. You saw that?
Yeah.
Can you appreciate that?
Yes, sir.
Yes.
Stop there. और जाना दो और बाहर से आ जाएगा. We can hold it out.
So very good, Dr. Sandeep. I think now your plan is to dilate the tract. So till that we are going to the another room.
So I will just tell the next few steps which we may do in your absence is to pass a cystotome over the wire, a 6 French over this short wire only. I'll go inside, exchange with a longer wire, hold that wire and then place a stent. So we'll get you back once we are placing the stent.
And Dr. Sandeep, sometime what we do, we take out the wire through the drain and we hold the wire.
That's what we have done.
We have done that.
We're already holding the wire. If external camera can show that, if the cameraman can leave his cell phone and come here, please.
Because that give a lot of strength to pass the stent.
Can you focus on my hand?
If the cameraman can show the hand of Dr. Nikhil, you see the Nikhil is holding the wire now.
Yeah.
Thank you.
Okay, thank you, Dr. Sandeep. And we are going to Dr. Vikram Bhatia. He is going to demonstrate a case of ampullary adenoma.
Somebody
over to Dr. Jubin.
Thank you, sir. So the next case we have is a 50-year-old male who had painless progressive jaundice for last 3 months with some weight loss. He has been evaluated previously, and these are the labs. The Billy is around 11. The CT shows IHBRD with smooth distal tapering CBD. These are the endoscopic images. So the plan is to assess using in EUS whether we can do any resection and how do we plan for resection for periampulary adenoma. So over to you, sir, in OT3. You were live, sir.
Hello everyone in the hall, can you hear me?
Yeah, Vikram, you are audible.
So good morning and thanks to Rajesh for this opportunity. It's a wonderful case. Professor Newhouse is here with me and this case was actually planned as an ampulectomy for him, papillectomy for him. And this is a pre-resection EUS study. Gaurav is behind me, everybody knows Gaurav. And in the room, I have Manoj, the technician, and Vinod, who is the main ultrasound go-to person for Fujinon. They are here with me. The scope in hand is the Fujinon latest display 580 UT paired with the Ariata 850 machine. So I hope to show you some wonderful images. My voice is clear there?
Yes. Clear.
So I had some time on hand while Sandeep was showing there. So I have the papilla on focus. I'll show you the key structures for orientation. This is the probe. I am instilled water to keep a adequate focal distance from the lesion. So the folds are separated and the acoustic coupling happens by water installation. So you see the lumen is distended. You see the bile duct stents. This gentleman has been stented. So it helps me, but it also hampers me. There is a stent in the bile duct and there is also another stent in the pancreatic duct, which I shall just show you. So he's been stented. So the question here is, he has an ampullary lesion. You all saw the history and the decision to be taken now is whether ampulectomy is the right treatment for him. So, Dr. Newhouse, I went in with a US scope, but in general, the first thing you look at is endoscopic view of the papilla. The papilla was not smooth, it was bossylated, but there was no papillary roof ulceration and there was no papillary ulceration. So that was one, but it raises an alarm that it is not a adenoma of the ampullary duodenum. It is a non-exposed intra-ampullary tumor.
You can also, in case of if patients are
Give a mic,
jaundiced,
mic.
and this patient was jaundiced before, this is always suspicious for cancer and not for just an adenoma.
Yes, so the presence of jaundice should raise our hackles. And then, so the first thing is endoscopic evaluation. So we feel that it is an intraampullary tumor. And the tumoral dysplasias, which Dr. Newhouse would have resected here, are now called IAPN, intraampullary papillary tubular neoplasms. But these have a high incidence of going malignant. And I'll show you that I don't think this is a very good case for a resection and we can differ.
What are the wall layers involved?
So I'll show you the wall layers. So these are the mucosal layers. Just a minute. So this is the interface echo. This is the muscularis mucosa. This is the duodenal submucosa. And as you would conceptualize, the ampulla is a common channel inside the duodenal submucosa. It's an intra-submucosal structure which we want to resect. This is the muscularis propria of the duodenum, and deep to it, behind it, is the pancreas. So the CBD comes from here, the PD comes from here. Normally they would join close to 2 millimeter outside of this duodenal muscularis propria, penetrate it, and then form a common channel of 9 to 28 or 20 millimeter or so, depending upon the length of the common channel. So the ampulla is the structure which is inside the duodenal submucosa. So you see the hypoechoic tumor, and immediately certain things are very evident. I'll use my cursor to show. You see that the interface between the hypoechoic tumor and the duodenal submucosa is very irregular. This is speculated. I hope, Dr. Newhouse, you agree with me that at least this is Japanese D1 and certainly not D0. And the very fact that there is some mucosal invasion or some mucosal irregular interface speculated suggests that this may be an invasive cancer and not simply a tumoral pre-invasive intraampullary adenoma.
Does it involve the muscularis propria also?
Yes, so
T2 stage. Huh?
So at least this is T1b in this image, but then let us see the muscularis propria as Dr. Newhouse has said. So excusing for some stent-related artifacts, this is the muscularis, and you see that the tumor seems to go right across the muscularis. So it is not only invading the muscularis, it is going through the muscularis back into the pancreas. Am I comprehensible to the audience in the hall?
Yes, Dr. Vikram.
Okay, so here is the CBD, the stent marks it. This is the tumor, and you see how it perforates through the duodenal muscularis, not only invades it, but goes through it and enters the pancreatic parenchyma behind. I'll rotate over it so that you better appreciate this. You can see here.
Dr. Vikram, whether elastography also will help in this lesion?
So see the tumor going outside. This is the duodenal muscularis. It is going through and through. So immediately, even though the biopsy was a adenoma, but when you do an US, you realize that the negative predictive value is not very good. Biopsy can miss a cancer, and hence the utility of US. I think I'm really convinced that this is the adenocarcinoma, and the distance of infiltration. I'll just come to your question, Gaurav. The distance of infiltration from into the pancreas very approximately
Vikram, will it become a T3 lesion now because pancreas is involved? And then one.
So see the distance of infiltration, it is close to 12 millimeters. Anything more than 5 millimeter is T3B.
So can I interrupt Dr. Vikram?
Yes, Rajesh.
The endoscopic ultrasound done outside in the prestigious institution in the Delhi.
Okay.
And what they have not written this report, could it be a part of ERCP induced changes? I do agree because I put the stent, bilirubin was 24 on table. My thought was this is not the right case. And that's why we have not kept this case for ampulectomy and we changed to other case which was done by Nihos.
Rajesh, you can see what is in front of us. See the tumor, see my arrow. This is tumor, this is not infiltration. See the tumor go through and see the tumor go through. If you are receiving good enough images, see what I am tracing. This is tumor. This is definitely not there is inflammation. I agree, there is inflammation here. I'll show you. This is tumor. You can see the little plant polypod things growing inside the duct. See how it goes. See the spiculated margin into the submucosa. That's the key of a good diagnostic evaluation because it's a very subjective thing. Another operator may say one thing, but then you have to have experience and conviction to differ. Definitely, this is not
Thank you, Dr. Vikram, for this information, and we are not going to keep this case for ampulectomy. And I request Dr. Jubin to go to Dr. Pramod Garg, who is waiting. So thank you, Dr. Vikram, and
thank you.
Over to Dr. Pramod Garg.
So the next case that we have is a 49 male, acute necrotizing pancreatitis since September 23, and currently he has come to us with abdominal pain since 15 days requiring painkillers. There is some early satiety with weight loss. This is the images. The images shows a large pseudocyst versus Vaughan. So the plan is for EUS assessment and drainage depending on the amount of debris. So over to you, sir, in room 1.
Can you hear us and see us?
Yes, sir. Yes, we can hear and see you.
So this is a young man with acute pancreatitis with a large pancreatic fluid collection, which is likely to be walled off necrosis. It is, I think, persisted for about 7-8 months now. And on CT, if you see, it is reaching right up to the porta hepatis. So in such a case, you have to see whether the fluid collection is actually in the lesser sac or it is anterior to the stomach. But if you can see the duodenum wrapping around it, and if you see the CT again, you can see that, then it is in the lesser sac reaching up to, because it's large in size. But on CT, you can't make an assessment about the amount of necrotic debris within it. And for that, either you do a T2 weighted MRI, or sometimes large cyst abdominal ultrasound can also tell you that. But when we are doing EUS guided drainage, because he's symptomatic, then on EUS, you can also make an assessment about the amount of debris inside. But that is, not a very accurate assessment, but still one can see that whether it is less than 50% or more than 50%. So once the anesthetists say go ahead, we'll start. Okay. So this patient is being done under conscious sedation. They have not intubated because they find that generally they do without intubation. Although my personal preference in patients with large fluid collection is to do it under intubation, because many times a lot of fluid comes in and there could be a risk of aspiration. Would you like to place a nasal tube, please? So they will place a nasal tube so that suction becomes easy.
So, sir,
Yes.
as you mentioned about the anterior collection and the lesser sac collection, so for the postgraduates, would you like to explain whether you will not do the drainage in anterior collection, or how will you change the management if it is an anterior collection?
I forgot to mention that with me is Jamil from PGI and also Deepak from AIMS, and also Bhagwan is here with me, who is going to assist us, and there are many others. I don't know the name, but Dr. Pawan is here from anesthesia team. So, Jamil, the point is, if you have an anteriorly placed collection and you do cystogastroscopy,
yes, sir,
sometimes there's a risk of leakage into the peritoneal cavity, and then they may develop peritonitis. So I would like to avoid that.
Yes,
so
sir.
what I've done is I've gone towards the antrum, and now I'm turning my scopes towards the posterior side like this, and slowly withdrawing it to see where am I and where is the collection. So now you are starting to see the collection here. And you can see this whitish thing is the debris within it. So the things that you have to assess before you plan drainage, in fact, there is a lot of debris here. And my suspicion is definitely it is more than 30% of the volume. That's a visual assessment, but that's what I think it is. Any opinion, Jamil and Deepak, would you think it is likely to be more than 30% at least?
Yes, sir, it seems to be at least 30%. Because
more than that, yeah?
Yes, sir.
So there's a lot of debris. So one is that you assess the amount of debris, and that will tell you what kind of stent would you like to put in. So what we have seen that if the debris is more than 1/3 of the volume, it is perhaps better to put in a metal stent than plastic stent. That is one. Second is choosing the position for cystogastroscopy. There should be minimum distance between the gastric wall and the cyst, and you can see here the distance is really not much. Third is that you should be puncturing the stomach and making sure you're not at the lower end of the esophagus. And for that, fluoroscopy is generally helpful to show you that your scope is below the diaphragm.
Yes. Put up kar de.
And also you can make an assessment about that on endoscopic view also. See, I'm here, I'm below the GE junction, and this is at the upper part or proximal body. So most of the time when you do cystogastroscopy under EUS guidance, you end up doing it proximally. When we were doing it earlier under endoscopic guidance, it was mostly in the distal part. So the third thing you have to see, besides the distance, if there is an intervening vessel or not. Can you put the Doppler here? So there is some vessel here. Now what happens many times, because the cyst is large, it compresses the vessels. So even if you don't see, it may still be there. One of the things you can do is to release your knob here and don't oppose your echo endoscope against the wall. And then you can relieve some of the pressure and see whether there is a vessel in between or not. So I've released this up-down knob, and I don't find any vessel there. So it seems okay to me. Deepak and Jamil, what do you think?
Yes, sir, perfect. I think that is a very important tip that you shared, that you should not pressure the stomach so much with the echo endoscope. Otherwise, it can lead to, it can disappear or even compress the vessel, and can lead to bleeding at the time of puncture or the fissular tract dilatation.
So our plan is to put in a metal stent. I'm using a 19G needle here, Cook 19G needle here, and through which we will pass in a wire, and then we will use a cystotome to go in. Is the plan okay?
Yeah.
So I'm taking the outer sheath out now. Can you see the outer sheath there?
Yes.
Okay. Can we zoom the upper part? So
that's okay. So I've removed the stylet little bit here and fixing myself. Little bit tangential here I am. So now I'm inside the cyst. Withdraw the stylet here and aspirate the fluid. Two reasons for that. One is that you can actually take it for culture if you suspect infection. In this case, it's a long-standing cyst, unlikely to be infection. And second is you can always see whether there's any hemorrhage or not. But the fluid layer looks quite clear here, so we are okay. So he's passing in a jag wire. This is 32, 032, 035, 035 jag wire. So Dr. Malay Sharma is also here. Malay, what's your preference nowadays when you drain a cyst like this, where we have at least more than 30% debris? So the key thing here is to make at least 1.5 to 2 loops. And you can see we are making almost 2 loops here. And it's a very large cyst actually. That should be okay.
Yes.
I'm fine. Now, the important thing here is when you have to exchange accessories is to keep seeing your wire. You can't move now. I cannot move now. This is the key step here. I have to keep seeing this wire all the time. If I don't see the wire, then I'm in a problem. Okay? Then that means I may change the track, and I don't want to change the track here very clearly. Okay? Till such time, be slow, please. Slow. And I'll keep seeing the wire under fluoro also, but I have, yes. The reason is if you move and you don't see your wire, it will be very difficult for you to go through the same track again.
Dr. Pramod?
Yes.
Till you are dilating, can we go to Sandeep Laktakia is
You
waiting
can.
for 5 minutes?
Sure.
Yeah, Dr. Jubin, we can go to Dr. Sandeep Laktakia who is waiting for the final call, final stenting.
Hi.
Yeah,
Hello.
you're back, Dr. Sandeep.
Hi. So what we did in your absence was after the contrast went into the tube, the guide wire went into the external tube. We passed a cystotome, a 6 French cystotome over the guide wire, created a fistula between the stomach and the pancreatic tissue into that, and then exchanged with a long guide wire, which is now hanging outside and held back. Then we dilated the tract with a 4 mm balloon, and now we are placing a double pigtail stent, which is
7 French, 3 centimeters.
4 centimeters long. This is a little soft. So we are in the last step of the procedure.
Meanwhile, we have also pulled back the catheter a bit to allow space for the inner pigtail to take the space.
Sandeep, after the procedure, how do you plan to remove the external drain?
So we will keep it clamped for the next 24 to 48 hours. At that time, we will get a cross-sectional imaging, and if there is no collection, then we can safely pull it out, because then the reroute of the pancreatic juices happened into the stomach.
Should it be gradual or step by step, by a few centimeters every day, or?
No, we can just pull it out. We've already pulled about 2 centimeters now to create some space between the stomach and that cavity area now.
I was telling the same thing, Dr. Sandeep, because with the drain, when you place, there was no pigtail formation.
Yes.
And 2 of my patients, the stand migrated because I have not pulled the external drain. So it is important we should pull the external drain and then put the stent.
Give some space. If the stent goes in the external tube, the distal part, and while pulling out, we can actually accidentally pull the stent out. The whole exercise goes waste. So it is better to create some space, or do it in such a way that this does not pull out. You do it under fluoroscopy removal. Don't do it without fluoro. So this stent is slightly soft.
Sandeep, most of the stent will be in the tract only, not in the pancreatic tissue.
Going.
Yeah. So
is it going in?
The pigtail part will be in the tract.
It's in the tract only, yeah? That's what sometimes happens when we are away from the live. In one go, it finishes. Now it's going in. It's going in. Mark is seen. Yeah, it's okay now. Yeah. I don't see that. It's a radiopaque mark. Now you can you show? No. What? If the fluoro man can keep that tip of the endosonoscope in the center of the screen.
Can you put the scope
It's in the center. नीचे cut करिए नीचे का. हाँ. Okay.
What would be the length of this?
Release now. I don't see the radiopaque marker which was mentioned.
Scope
Yeah, you are showing.
You are quite deep in.
No, actually, I was told that X-ray, the stent is ready. Then I'll get to endoscopy image now.
We thought it had a radiopaque marker.
I was told that X-ray, the stent is radiopaque marker, but it's only a black mark.
Yeah, it's black mark, it's not
no,
radio
no,
opaque, and you are quite deep in.
No, that's what. Now I realize that.
We
Then you have
can
the
pull
floor.
we can pull the
Floor off,
external drain.
floor
It's
off,
going to
floor
help
off.
us.
NBA हटाओ इसमें से.
Sandeep, what would be the length of the stent which you are going to place? It's just like a routine pancreatic stent, or
Release.
It's a 4 centimeter stent that we put.
Release.
post?
So this is a 7 French, 4 centimeters double pigtail stent. So short stents are always better here.
Perfect position.
Actually, the tip is still in the. So I'll actually pull it out now. Pull it more. Pull it more. Yeah. I think then leave it. In fact, pull the whole thing out. I think now we are almost out. Take it out.
Thank you, Dr. Sandeep. Thank you for the nice demonstration. We go to Dr.
Thank you.
Pramod Garg room. Thank you, Dr. Sandeep.
Thank you, chairpersons and moderators. I invite the next set of moderators and chairpersons, Dr. Arvind Kumar, Dr. Kapil Sharma, Dr. Manish Bhatnagar, and Dr. Hemant Kumar Gupta. And the chairpersons will be Dr. Jeffrey George, Dr. Vinayak Kalla, Dr. Mukesh Nandal, Dr. PC Delai, and Dr. Devesh Yadav. And this is an announcement for the audience. Whoever is leaving early can have lunch at 12 o'clock. Lunch will be open at 12 o'clock.
So, can you hear us? So what we have done is we went in with a 6 French cystotome to dilate the tract, and then we used a 6 French hurricane balloon. 6 French hurricane balloon. 6 mm hurricane balloon. And now we are using a Hanaro metal stent, 16 by 30. And you see I can keep seeing my wire here, which is very important. Even though you have dilated the tract, it is always important that you keep seeing the wire so that you know you are at the shortest tract through which you had gone earlier. So this is extremely important step. And now I think
थोड़ा बाहर पे ट्रैक्शन देखिए. Now it is in perfect line. Yes, so it has entered now. Yes.
so. If you notice here, can we go to the endoscopic image, please? So now you can see the fluoro image, and we will see the endoscopic image soon. Okay. So the problem that we faced little bit was that while introducing the stent, we took a while to introduce the stent. Okay. And the reason for that sometimes is that one, we dilated only with a 6 millimeter balloon. The size of the stent here is, the delivery system is 10.5 French. So that is one reason. And second is that if your entry of angulation, the entry is little angulated, you may find it difficult. So I find some bleeding here, and the fluid is coming out of the cavity. And if you see the fluoroscopy markers, I think most of the stent is inside, so I'll have to withdraw the stent here. And so this is the.
There is always a confusion whether to deploy under endoscopic vision or under fluoroscopic vision. So, sir, what would you prefer? Would you like to deploy with using a yellow marker under endoscopic vision?
So I use both actually.
Okay, sir.
We'll have to use both fluoroscopy and endoscopy marker.
Okay.
So there's some bleeding here, but I'm okay now.
Okay. So you think that that bleeding will be controlled with the
With
tamponade
the
effect? of
tamponade
the
effect,
stone?
okay.
Okay.
And you see, it is not that much bleeding. It is
Yes.
the fluid which is also coming out.
Yes.
So now we can start deploying the inside view, but I also see the, okay. Yes. Huh? I'm okay.
Yes.
Do you think that? No, no. So what happens is when you deploy, the stent actually tends to move in and you have to keep a traction.
And
just wait, jaldi mat karna. Yes. Wait. The coordination between the endoscopist and the assistant, very, very important here. Can you see that no, wait. Unless I say don't do that. Very important. Unless I say don't do it. Okay. So I think the inside flange has opened. Can you see that?
yes.
Maybe we can take a picture and you'll see it better.
Can we zoom the fluoro for the better visualization of the stent?
Can you see that? Did you take a picture?
Sir, fluoro.
Partially opened.
मैंने छोड़ दिया.
Fluoro.
This is not open.
Fluoro करना है, हाँ. हाँ, ठीक है. Now it is.
Can you see that it is open?
Yeah, it's open.
Okay. So I'll go a little away from the puncture side so that I have some control over this, and then I'll ask him to deploy again. And it will tend to move in at the last minute. So that's very important. Deploy now. Wait. Yes. Keep seeing the inner flange whether it is open. Huh? Wait. The inside is open. Wait. 50% is open.
Yes.
Wait. No, don't be in a hurry. Huh.
Spontaneous.
Okay. I'm keep pulling, don't worry. I'm keep pulling.
Perfect.
Yeah, that's it. Okay.
Amazing.
So if you notice here, the assistant is the most important person who has to be with you all the time. So Bhagwan was telling me what to do, what not to do, and this is very, very important, I can tell you that. Because at the last minute, the stent will tend to migrate. And he very categorically told me that the black mark has to be out. The black mark has to be outside so that we know that it doesn't go inside. So Malay, any tricks here when you are deploying a metal stent like this so that you can prevent migration either inside or outside?
No, I don't have any, Pramod.
Okay.
I think you have told all.
So one of the things now, questions, there are many questions at this juncture. One is, should I put in a plastic stent through this or not? In infected necrosis, I would definitely do so. In sterile, I'm not too sure. We can still put it. The other is whether we should do necrosectomy or not, upfront necrosectomy. And I think you heard the talk yesterday.
Very well done, sir. What is your choice, hot versus cold, for the pseudocyst drainage? Hot stent versus cold stent.
Hot stent versus
so
cold.
Hot versus cold, I think it is personal preference. One is that the hot stent is faster. It doesn't require any previous dilatation. You can do it easily. There's no problem. And it's a little bit expensive. The advantage of using this kind of stent is it is softer. And some people prefer this. Although the steps are longer here. You have to, puncture the cyst, dilate it with a cystotome, again dilate the tract with a CRE. and then deploy the stent.
So thank you, Dr. Pramod Garg, for the nice
So should
demonstration.
we place a plastic stent? I will tend to place a plastic stent here. Rajesh, is that okay with you?
Yeah, it's okay. You can do off camera. Can we go to other room?
Yeah, please do that. Okay,
Thank you. And we shift to Dr. Jubin. Dr. Jubin. We can go to the balloon case. Yes, thank you.
Yes, so the next case that we have is a 46-year-old male, post ALDLT for ALD and CLD, now has a metabolic syndrome, BMI of 36. The plan is for intragastric balloon for weight loss. So over to room 4.
Everybody, I would like to thank Dr. Rajesh Puri sir for organizing such an excellent conference and giving me opportunity for this. As we all know, this obesity is rampant in India also, and we are going to have Western like obesity we have. This is we are putting Orbera 365 new intragastric balloon. Previously, the Orbera balloon was only can be put up to 6 months only. Now this Orbera has 365. That means you can put this balloon for 1 year.
Sir, is this a new design? Usually the old balloon had a white covering. This is something blue. So can you explain it?
Yeah, because the sheath of this Orbera balloon was tear off before. So we made it ourselves, the sheath, by cutting this gloves and putting it on this as a sheath. This balloon has a catheter which is attached to the saline, and then directly we can push it through this channel, and we can put around 400, 500 or up to 600 ml of balloon. But in our Indian people, usually they don't tolerate 500 to 600 ml of this fluid, and they start vomiting again and again, and then sometimes we have to remove this balloon. So we would like to put 450 to 500 balloon. Now this balloon you can directly ask the patient to swallow when it is intact, and patient can swallow it, and then you can inflate, or you can pass a snare, and over that open the snare, and then over that you have to catch the sheath and lubricate it. So अच्छे से lubricate. You should apply a lot of jelly. Right,
Sir, SPAS 3 versus Orbera. What is your preference for the ease of placement?
Ease of placement, I think SPARS is much better. With Orbera, sometimes we have difficulty in passing this Orbera because they don't have any attachment. While SPARS has attachment which you can put it on your scope, and that easily goes. So I also feel this will be passing this will be a little bit difficult. So we have dilated the upper esophagus, upper esophageal sphincter before, and we have put a large mouth gag because it requires a large opening, because this balloon is little bit big with snare.
What about removal? Which one is easy?
Removal is easy. Removal you have to remove with the SPARS. Removal is very easy because they have a catheter attached to it, and removal of this balloon is little bit difficult because they have again a catheter which goes with the balloon. But here, as you see, it has slipped, and now we have to push with the scope. The balloon has slipped. As I told you that it will be a little bit difficult because we have to catch it again.
Do you intubate the patient before procedure or do it in the conscious
Most
setting?
of the time not. There was a lot of food inside, which we cleared before this. Tight.
Dr. Yogesh, what are the contraindications for the balloon placement?
Contraindications for any endoscopic therapy are large hiatus hernia and CA stomach. Large hiatus hernia is the main contraindication for doing any endoscopic therapy.
Ulcer also.
And even gastric ulcers.
Large gastric ulcer. Those patients have trismus and and mouth is not open. Yeah.
You ever do gastric empty scan before you place these balloon?
Which scan?
Gastric emptying study.
You are not audible. Which scan?
Gastric emptying study.
Yeah, gastric.
Yeah,
emptying,
yeah,
if you
yes.
suspect gastroparesis, yeah.
Then we should do it.
Always do it. See, pushing the balloon from the throat, still it is little bit of difficulty. And patient, I need a little bit more sedation in this patient.
Sanjay, what is the sort of weight loss you expect with a balloon in such a patient? What's the
Usually it is around 10%, sir. And as we know that all the studies says us that if you lose 10% of the weight by anyhow, and it reduces your chances of morbidity.
So, but in today's era of GLP-1 analogs, the weight loss is similar to endoscopic therapies with GLP-1 alone.
Yes.
So, are there any particular indications that we should do endotherapy or just offer GLP-1, which is easy
very
to
good
take?
question, Yogesh, because sometimes what we know that patients are on multiple drugs and they don't want to take multiple drugs and before surgery, and they don't want to undergo surgery also. So they want something which they can, you can put it one time and they don't have to take drugs again and again. So it is around you for 1 year they are off drugs, and for GLP-1 they have to take drugs daily or they have to take injections weekly.
That's true, Sanjay, but what is the durability of this weight loss with balloons?
All weight loss procedures, they have durability. They have the studies around 1 to 2 years or maximum studies around 5 years. So durability with balloon is also for up to 3 years. They have 3 years. They have sustained weight loss around 10%, and if it is combined with the drugs, they are having good weight loss.
So in your routine clinical practice, would you put these patients on drugs also, or do you think the balloon?
Yeah, if they are affording, you can put them, because what happens is these patients are obese, but if you put them on these anti-obesity drugs, it costs around 300 rupees per day. Remove.
And sir, if you are not having the desired weight loss, always you can add GLP
Yes,
also.
and they act simultaneously. Yeah, they act simultaneously. So I think because the balloon sheath was ruptured, we are facing some difficulty while passing it through the throat.
Sanjay, if you had intubated the patient, would it have been easier?
No, it would have been more difficult, sir.
More difficult?
It would have been more difficult. So I think we have to push it with the scope. And there is a challenge in pushing it with the scope. So I think we will put it again. See, it has sheath has been ruptured, so it has become like a big balloon. That is why the problem occurs, and they don't have the second balloon. So we will make some attachment with this, and we will put it again. So till that time, you can go to some other room, and we will make another sheath over this. एक और वो दे दो gloves. बड़ा चाहिए, बड़ा glove.
How much dilatation required before placing these balloon?
No,
usually don't require. We don't
Usually not
require
required.
any dilatation.
But in this case, as the external sheet was newly made, that's why we dilated it for easier administration, but still we are facing similar problem. You are placing a new sheet above that.
What is the advantage versus the Sparks balloon?
They are two different companies, sir.
But
there is no both have same results, sir. So
apart from that, in Sparks you can instill fluid up to 750 ml if you don't get a desired weight loss after 500 ml. But again, in Indian patients, it has been observed that Indian patients don't tolerate fluid more than 400 or 500, and Sparks can be kept for 1 year, which Obera also has now a new balloon called Obera 365.
And does it allow graded installation of fluid?
No, not in Obera, but in Sparks graded is there. But as I mentioned, all studies have shown that above 500, 400 Indian patients don't tolerate.
Now we will put an overtube because the sheath has become a little bit more robust and thick. So we'll put a small over tube up to his stomach and then we will put this balloon. That is another idea which we are going to do. पोप के ऊपर ही चल गए वो निकाल दीजिए ना चलिए वो उसके ऊपर जाएगा
Dr. Yogesh,
yes
do you recommend H. pylori eradication before placing these balloon? H. pylori eradication.
Basically, there is no such recommendation to treat H. pylori, but yes, if patient is already known case of gastric ulcer or duodenal ulcer, you can always treat that if he is a known case of that. Otherwise, there is no such recommendation that you should treat H. pylori before placing balloons or any endotherapy.
As we have dilated, the putting the over tube will be little bit easier than the normal case. We are just going in with the scope and now we will slowly pass the over tube. Slowly. So you can focus on my hand. I have put this over tube as we put a dilator over the wire and it has reached the stomach.
This over tube we use in the double balloon endoscopy is something different over tube.
No, this is a Gardner's over tube by Studies. So
same used in the ESG.
Yeah, we can
Almost
use
same.
that one also. We can use that one also.
Jelly लगाओ ऊपर से
अच्छे से jelly लगाओ नहीं जाएगा डालो
So this is also very important that initial handling of balloon is very important. What happens usually we remove the balloon, then it goes through 3-4 hands.
So
Everybody
Dr.
wants to
Harwani,
see it. Yes,
Dr.
sir.
Harwani, till you are preparing, we are going to
Yes.
Dr. Malay Sharma room,
Yes,
and I
yes.
request Dr. Jubin
Yeah.
to go to Dr. Malay Sharma room, please.
Definitely.
Yes, sir. So the next case is a 41 male who during an ERCP for a CVD stone was found to have a lesion just next to the ampulla. The biopsy showed to be an NET. DOTA scan was negative. Now again the plan is what to do with this lesion, whether we can do any endoscopic resection. I think the best person for this would be EUS by Dr. Malay. So Dr. Malay, sir, we are live with you in your room.
But
Please
they
go ahead.
say that only bile duct stones, this patient, or was the patient jaundiced because of
Bile duct stones are also there now.
why did he receive
live? Okay, so we are live, I think.
We can hear you, sir. We
Ah.
can hear you.
Yeah. So we are now in the second part of duodenum, and here is where in the second part of duodenum we are seeing that this is the muscularis mucosa, and this is the muscularis propria, and this is the submucosal line. I am going to trace this line so that I can follow where it becomes a tumor. Once I rotate and trace this line, I am find a lymph node here. I will apply color, and this lymph node is definitely in a periduodenal area. We'll talk about this lymph node there, but I want you to follow this muscularis mucosa and muscularis propria at this place. Here is where, at this particular place, it becomes different because it converts into a tumor, and that this area is becoming a tumor. The question here is whether this tumor is going outside the pancreas, outside the duodenal wall or not. So in this case, the presence of stent is causing problem for me because I am not able to demonstrate it so well. So let us try what are the ways by which I can find out whether this tumor is invading outside or not. So I have gained the maximum highest frequency. I will increase the frequency to highest, and then I will try and follow one by one. This is the muscular layer, or this part is okay. Now this is the pancreatic duct. When I follow the pancreatic duct, I am finding that this pancreas, the muscularis layer is here, but this pancreatic duct, this is now the tumor is very well seen. This is the tumor, and this is the place where this is the muscularis pancreatic duct I must see. So I want to show you that yes, please, and I will show you that this pancreatic duct, as I see here, at this particular place, the dilated part of pancreatic duct here is about measure is about about 2 millimeter, 4 millimeter away. So that means though on endosonography we are not able to see, but this pancreatic duct is all here. There is a different view. I am able to see the pancreatic duct here in this frame at this place. So this pancreatic duct is here. It is sort of tapering. I will zoom it even more to see whether there is a tumor extension here. So is it a natural termination of pancreatic duct or there is an extension of tumor into this part? I am not able to say. So gray zone. Now I will see the bile duct. Since this bile duct is full of stones, as I say, I will see that this bile duct, is it involved or not? So what are the ways by which I can say that this tumor is involved? Of course, I would have loved to do it in a clear-cut case, but here this tumor, as you see, if you compare the echogenicity, this here is all same, and it seems that this tumor is extending just a little bit up to this point in the bile duct and pancreatic duct. So what makes it inoperable, in my opinion, it is not the CBD or unresectable, in my opinion, is not anything else but this particular lymph node that I am seeing here at this particular lymph node, which you can see that this is a peritumoral lymph node outside the wall of the tumor that you have seen on endoscopy. So this is the case of neuroendocrine tumor, biopsy proved, one lymph node present just outside the wall of the second part of duodenum, possible extension into the pancreatic duct plus or minus, I cannot make out, but no ability to assess common bile duct extension properly. So I think that is all. However, if you want more evaluation, I will come back quickly and I will try and go into the second part of duodenum from a bulb. I will see it from the bulb and see if I can make a different kind of evaluation from the bulb.
Maybe you can show the audience the lesion also, the endoscopic view of the lesion.
I can see it, show it the endoscopic view, because yes, so that is what. When we see it endoscopic view, this is the lesion and it looks quite attractive. But no, when you see, Dr. Newhouse, what would you say endoscopically? Is it resectable or not? Tell me.
Well, no, endoscopically, it's I think it's involving the papillary orifice and it's extending probably into the CBD.
Yes.
And for an endocrine tumor, we would need a en bloc A0 resection. This is not an adenoma, but an NET. And therefore, complete resection is necessary, and this is not achievable, what I think, with endoscopic techniques. We cannot, by the way, we can also not use the FDR system because we are too close to the CBD. Even when the stent is in place, we won't get it fully into the cap. This is impossible. To achieve en bloc resection, I just said, this is different from an adenoma. With an adenoma, you could still consider and follow it with RFA and so on. But here we need en bloc resection. And in addition, we have the suspicious lymph node. So this is a candidate for BIP resection. Yes. Yeah. Do you agree?
Yeah, I agree. And not only that, if I characterize the tumor, it is slanting. It is not going to be, it is not like a tumor which is encircled and all this. So this has got one ampullary orifice and this has got another dimple over it. So the presence, people who do early cancer, they can evaluate whether this edges of the tumor, they look like one thing. because it is a bilobe, something like a bilobe tumor, or even if it is single lobe, this is very close to the papilla. Okay. Now the only thing is, if I want, if I have time, I will just come back and see if I can show it to our audience by going into the duodenal bulb and how to find it from the duodenal bulb. So I have gone back to the duodenal bulb and I will just try to find out the neck of the pancreas. Once I find, and if there are any more lymph nodes. So once I am in the duodenal bulb, the trick is to move to the left and to the right and find the portal vein. So we have to find left and right. In this case, because of instability, I am slipping out. So I have with me Dr. Vikram Bhatia also. Dr. Vikram, can you please join us for a minute with a mic and if possible say why this periampullary tumor or neuroendocrine tumor is inoperable, if any more inputs we can give.
In this case, if you find a autocaval lymph node, so what it mean?
So till now, what we have found out that there is a lymph node, that is one thing, and then the second thing is I was able to trace the tumor. This is the pancreatic duct. Vikram, can you hold the knob? Yeah, yeah. This is the pancreatic duct, and then the way this tumor is there involving water. Can we have some water? Yes.
There are stones inside CBD?
There is a stent and stone in CBD. So this is the tumor that you are seeing. Yes. Yeah, this is the
So thank you, Dr. Malay.
Yes.
Thank you. You have done the demonstration.
Okay.
Dr. Malay?
Yeah, I think we are okay. That is what Vikram also said, that there is a lymph node.
Thank you. Thank you, Dr. Malay. And we are going to Dr. Sanjay Rajput. He is ready with the bib balloon. I request Jubin to go to Dr. Sanjay Rajput case.
Sorry, मैं उधर डॉक्टर घर के साथ बात नहीं.
Dr. Jubin? Dr. Sanjay, you are on.
Yes, sir. So finally, we put some rubber bands, which are usual normal rubber bands over this, and make it a little bit smoother and little bit slimmer. And then we could pass it again with the snare. We removed the overtube also because it was bigger for the overtube. So we removed it and we put the normal rubber band which we put in our hair. Ladies put in their hair, and we could pass it through this. And we have inflated it. You can see.
So how much volume you are going to inject?
We are injecting around 400, sir, because we have seen that after 400 to 500, patient starts vomiting.
And how much has been
do not
injected?
tolerate. Yes, sir.
How much has been already injected?
It is almost 400, sir. Almost 400. So now we will just pull this catheter. It is very easy. Removal of this catheter. You can focus on this hand. Okay. Yeah. This is the last syringe what we are pushing in. So then you just have to pull this catheter out easily. And now you can have a look at the balloon.
Thank you. Thank
so
you.
You can see the rubber band which was applied there has gone off by itself. So this is how you have to tackle the emergency, and you have to apply your mind.
Thank you, Dr. Rajput, for the nice demonstration.
Thank you, sir.
And we will go to Professor Nihos' room where he is ready with the laser lithotripsy. I request Dr. Jubin to present the case.
So the next case that we have is a 37 male who had a gallstone disease with CBD stones, underwent CBD stenting, lab chole is done. Since then, he's having recurrent episodes of cholangitis. Multiple attempts has been done for years for CBD stone removal, but it was not successful. This patient has come to us with recurrent fever. This is the imaging, the MR available. The plan is for ERCP and CBD clearance. Over to you, sir.
Sir, you are online. Okay. Good morning, everybody. It's a pleasure to do this procedure. I'm assisted by Dr. Jin back one is assisting me again. So I just removed the double pigtail stent, and we see here a nice opening of the previous sphincterotomy. So because I don't have seen appropriate ESCP images, I would like just to see where the stone is located. So I'm using a stone extraction balloon catheter. Okay, so we can now block the, and inject a little bit contrast. So, okay, the stone. Okay, stop. Yeah.
Dr. Jimil, it is always necessary to do cholangiogram before we perform a laser lithotripsy.
Yeah, because I haven't seen appropriate images from the previous ESCP. Otherwise, it's not necessary.
Sometimes
so we have seen the stone is obviously impacted at the cystic duct junction. So it's a kind of a Merici syndrome. We see the cystic stump, so deflate the balloon.
So, when you inject the contrast before the spyglass, do you find any difficulty because there will be some amount of glaziness of the contrast?
But with flushing, this will quickly disappear. Yes.
Okay. And
so,
with this impacted stone, will you go ahead with first an attempt of the mechanical lithotripsy
no.
or no? You will directly go ahead with the single operator cholangioskop.
Because firstly, this has been already done.
Okay.
And secondly, if the stone is partially involving the cystic stump, then it's impossible to entrap it in a basket. Huh?
Yes.
And therefore, it's also time saving if we directly proceed to cholangioscopy. So could you please connect it? Firstly, so you have, I think, already seen spyglass. It's a 10 French steerable catheter with 2 LEDs with separate two separate irrigation channel with a 1.3 millimeter working channel. It's already preloaded here with the laser fiber, and we also connected to a water pump. I need the flush for water pump.
When you require a guide wire assistant to place these cholangioscope into the CBD?
No, not. Firstly, in this case, I think it's not necessary because we have a large opening. And sometimes when you are in the duct, you remove the wire, then it can be difficult to place, to insert the laser fiber through the scope. So now we reconfirm that the tip of the laser fiber is close. You see?
So it is very essential because once the spyglass is banned, it is very difficult to bring that laser catheter outside the spyglass, especially in the intraductal channel.
Yeah, I already have problems to insert.
Better to place a guide wire, even though in the channel we can see.
Yeah. So I check.
And Professor Nuhas, here in this case, the papilla is adequately dilated, but let's say if it is a naive case, in that scenario, would you like to do EPBD in all the case or just a liberal sphincterotomy is adequate?
Yeah, of course, I would do, as I mentioned in my lecture, EPLBD.
EPLBD,
yeah.
Okay.
But here is, I think it's not really necessary. Papilla is nicely open.
Opened, yes.
Dr. Jimmy, can you tell us the specification of these laser fiber, their size and then power?
I think this is
diameter of these laser fiber, die of these laser fiber.
Yeah.
So
dia and length, I think, is important.
Let me see.
Dia is also important.
Yeah, dia and length.
Because they are finding difficulty.
I think, okay, now do you see this? I think this is a holmium 250 micron fiber. So I pull it back a little bit. Now I lock the wheel of the valve, and now I advance.
Any trick specifically you did to make it easy for the fiber to come out?
Yeah, as you have seen, I'm pulling it back in a straight position. In the straight position. So now for insertion, I'm going very close to the papilla. Insert the tip a little bit. Then I lift it up. So I lock the wheel, I push it a little bit deeper. And then I advance the duodenoscope more deeply into the duodenum to get it in a good straight axis. And I'm already obviously in the duct. And now we may switch that I have the large image.
I think these steps are very crucial and very essential, how to enter into the papilla with
Yes,
this
and
bulky device.
yes, but also it's also important to control the duodenoscopic image, because sometimes we are so fascinated by cholangioscopy that we lose the position.
Yes.
So, and now, as you can see, I carefully advance the scope forward, and we already see the stone here. And let me see, this is on the left, you see at 7 o'clock the cystic duct.
Yes.
So it's obviously just close to the cystic duct. Later on, we can also intubate the cystic duct.
Okay.
But this is obviously the CBD. So now I'm opening the wheel and I'm advancing the fiber. Open. So fiber slowly comes out. And now the next challenge is to get it. This is what you mentioned before, that we have still a little bit blurred image due to the
because
contrast.
of the contrast, yes.
But this is also important since we have a large opening of the papilla, we won't increase the pressure of the duct.
Yes.
The water comes out. So, and now we have to touch the stone. Okay. And now we activate. Let's activate. I'm going even closer. So fire. Okay.
Fire.
Fire.
So what is the mode? It is, will pulverize the stone or will popcorn mode, or there are different modes?
The laser fragments into smaller particles compared with EHL.
Yes.
This is the advantage. The laser is very effective. It's less effective, what I think. So many, even experts, you sometimes hear in live demonstrations, when it's difficult to fragment a stone, then they say the stone is very hard. But from the physical flush, from the continuously, okay, stop. From the physics, it's not a matter of hardness. It depends of the brightness of the stone. The brighter the stone, the less effective the technology is, because less light intensity is absorbed.
Yes.
That means the calcified pancreatic stones
Yes, sir.
or brightish cholesterol stones are difficult to fragment. On the opposite, pigment stones are very easy, but here it works very well.
So,
Bachman, you are excellent. Yeah, very, very good. So, yeah,
and I think
fantastic. So, and you see, I'm very good control here, continuous flushing, always watching also the duodenoscopic image. And even if I would, it incidentally hit the wall. So I never had a temporary mild bleeding can happen, but I've never seen a perforation or a heavy bleeding.
like you are almost doing like a carpenting of the pulverizing the entire stone in a very rapid fashion. So we always afraid of bleeding or perforation, which is more common in laser compared to EHL.
Yeah, but this is also important. Always to watch the tip of the fiber. Huh?
Yes.
So when I'm going now, I'm out of control. It's out of control.
Weakened,
No?
yes.
This is therefore readjust the position of the fiber, and we nicely see. And as you can see with spyglass, how easily it can maneuver.
Yes.
To get it in the fragments which I wanted.
What is the laser setting we are using here? Laser setting. Can you focus on laser setting?
It is on the opposite. It's a 10 hertz and
10 hertz
and 1200 microjoules.
Yes, and 1200. So it's a very high energy.
One of the most important problems is that once you're doing the laser, you tend to slip out of D1 into the pylorus. How do you address that issue?
I think already Professor Nuhas told that while doing a spyglass, it is very important to keep control on the duodenoscope. It should not happen that duodenoscope is falling back because your both hands are on a spyglass.
And you see the fragments coming out. You see the duodenoscopic image.
And camera can focus on Professor Nuhas' hand, that how beautifully he is controlling both spyglass scope as well as the duodenoscope. He is maintaining traction on the duodenoscope so that it doesn't fall out. And I think it is very important tips. And another important thing is that while doing a spyglass, it is usually you should try to intubate, because lot of amount of fluid will come into duodenal. And if you are not able to suck it completely, it can lead to a micro aspiration or an aspiration.
I agree. Or you have to place a nasogastric probe.
Yes.
That during the laser, with the problem which we are facing, we end up making a tunnel inside the stones once we are using the high frequency rather than actually breakage of the stone.
Yes.
How to tackle them?
Yeah, but you see now you catch the edges, and now I'm through, as you can see.
Yes.
I'm already through the stone. And so this is so nice that I can now focus on the lateral part of the stone. We are right. We made a hole through.
You start with the center, go to the lateral. How you do that?
Yes.
Or you just?
It depends on the individual case. You can
also Professor Nuhas is doing this exact same thing. He made a beautiful hole and a complete thorough hole in the central part, and now he's dissecting the lateral part to break the stone.
Yeah. And now the question is, how long should we proceed? Huh?
Yes.
So nurses sometimes then say, is it not enough?
Yes.
But I think
long tunnel inside the stone also create a problem.
Pardon me?
Sometimes we end up with the long tunnel in the stone. Then there's some dissection of the lateral margin is difficult.
The question he is asking that what are the tips that once you created a long tunnel inside the stone, how will you ensure that there are adequate amount of small fraction on the lateral side? What are your tips in doing a good?
Just to go back, to pull it back, and to start again from the distal end as shown here.
Yes.
Yeah. So you see, we fragmented. You nicely see. I think it's already fully fragmented.
Yes. Very beautiful. Amazing.
So you see, I don't touch the fiber. I just manipulate the tip of the scope.
Yes.
And always also watching. So now we have, I think, a nice fragmentation.
So let's say, Professor Nuhas, there are multiple stone or more than one stone. The first stone you have already broke down like this. Would you like to now remove the small fragments and go ahead again, or would you like
see?
to?
Let me just see. I carefully go above the stone. To see if there are more stones. Yeah, there is. Now I'm probably close to the hilum. Fire.
You will remove these fragment at the end, or you try to remove these fragment in between and then again go with the laser and break the remaining part. What is your preference?
So we usually try to, if it is hindering the further breakage, or if it is coming in your vision and you're not going above the stone, then would like to remove the fragments and go ahead again. But if it is a small stone and the fragments are not coming in your path, then you can try to complete the laser or EHL and remove the fragment in the last of the procedure.
Yeah, we can also inject contrast in between, but I think so. Now, when you advance the scope, pull the fiber back.
Yes.
Okay.
The most problem with the moving stone, this very small stone which is moving, then you start firing and then start bubbling and moving, then it's very difficult to break them. How we can go for them? The moving stone in the bile duct, large moving stone in the large diameter bile duct.
Yeah, but you can easily follow the stones. Fire. you can easily follow. We can reach any part of the bile duct.
So
Even when stones moving, you follow, you don't push too much.
yes. And you can corner them in one of the wall,
Yeah.
and then you can do the laser. Exactly what right now Professor Nohas is doing, that he has made some of the fragments are still large, so he is cornering them in one of the wall and now doing the pulverization.
Slight charring on the bile duct doesn't matter. Slight charring on the wall of bile duct.
Yes, so there are 1 or 2 white spots. Do you think it can lead to any problems in
No,
future?
no.
Okay.
No SSL. So I think we should be close to the hilum.
Water, please. Yes.
Yeah, there's a hilum.
Yes, that's a
Can you see?
Yes, beautiful.
This is a hepatic confluence. Have you seen that?
I think so, yes. Or you can go ahead and show them again.
Fire.
The speed with which Professor Noahs is doing laser is,
Fire.
is really magnificent.
So I show you the hepatic confluence again.
Yes. Yes. This is the hepatic.
Are you convinced now? No comment.
No. Yeah. 100%. If there is hepatic confluence, I'm just waiting for the
But the
moderator's response.
Moderator.
I'm not sure whether.
Are we still online?
Yeah, you are online.
Okay, so Professor Nohas has shown the confluence and it is completely clear.
Okay, and now I think it will be easy to remove these fragments.
Yes.
Can we identify the left or right duct on the endoscopic, the bile duct image, cholangioscopic image itself without fluoroscopy, and in particular direction, diameter of inlet and anything?
Yeah, but what I will do now is just to evaluate the cystic duct. So we go back.
So sir, in this scenario, would you like to go ahead in the intrahepatic channel, or you are sure regarding
No, not yet.
No, not yet. Okay.
I don't think there are stones in the intrahepatic.
Okay.
Because otherwise I don't want to flush fragments in the intrahepatic.
Yes, and it can lead to unnecessary cholangitis risk as well.
Yeah, exactly.
These are small fragments
So,
which can be easily removed.
Here on, I think,
yes,
here is the cystic duct.
Yes.
The cystic stump. So we can even insert the cystic stump. Yeah. We are far in the cystic duct.
Yes.
Fluoroscopy, just to show those who won't believe. Yeah.
About to enter into the gallbladder.
Yeah. No, there is no more gallbladder, unfortunately.
Okay. Sorry. This is post-cholecyst. Yeah.
So you see the Heister valve from the, there is nothing left also in the cystic duct.
Yes.
So I think if you agree, we can now remove the scope.
Yes.
And proceed to removal just with conventional techniques.
Yes.
So where we expect the opening of cystic duct in the bile duct? Where we expect this opening of cystic duct into the bile duct? Actually, it's the same or right lateral. What's Dr. Jimil?
Yes.
Yeah.
So the question is that where should we expect the opening on the bile duct? It is always on the left lateral wall or the right lateral wall?
No. Usually it's on the left, but not always.
Not always.
No, not always.
And
But you can always identify the cystic duct orifice by means of cholangioscopy when you look carefully.
Yes.
So, and you see, we are now, we could continue fragmentation, but I think we should be able to remove it.
Yes.
Maybe
when we do the fragmentation, the microfiber touches the stone, or we have to keep it little away from the stone?
So in EHL, and what is the technique difference between EHL versus laser?
No, there is, in fact, so we remove that. I take it out. We pull the fire. Well, I think in terms of effectiveness, there is no significant difference, although no larger randomized control trial was done. But EHL fragments into larger particles.
Yes.
No? But it's also very effective. It is, of course, cheaper when you don't have the machine. But
Yes.
on the other hand, so we try with a balloon, yeah. But on the other hand, you have also to consider with the
Professor Nihos?
Yes.
Till you are completing, can we shift to the other room?
Yes, of course.
So we are shifting to the another room with the esophageal ESD. And I request my colleague, Dr. Bimal, to present the history.
Okay.
So this is a 70-year-old female without any comorbidity, present with non-specific dyspeptic symptom without loss of weight and appetite. On upper GI endoscopy, abnormal mucosa seen starting at 20 centimeter from incisors, extending till 25 centimeter. On NBI, it is IPCL type 4 and type 5-1. And on PET CT, there is mild FGG uptake with subtle thickening, proximal to the carinal level, no lymphadenopathy. And biopsy shows high-grade squamous epithelium, high-grade dysplasia with teeny foci suspicious for microevasion. So our plan is to do magnification endoscopy followed by, if feasible, circumferential ESD.
So over to Dr. Hatyavan, you are online.
Thank you, Professor, and hello everyone. I'm Dr. Taiwan from National Cancer Institute, Bangkok, Thailand, and here with me is Professor Hong. So now we are looking in the superficial esophageal lesions right now.
Yes.
And from what I see, now we inspect in the white light. So this how we perform the evaluation and access the lesions. Okay, it seems that the lesion is around 23 centimeter from incisor and goes down to 27. Okay, this is the white light.
I think on white light, you see disruption of a normal vessels, that longitudinal vessels along the esophagus, and you see different discolorations with somewhat erythematous or reddish lesion. But overall, it's still quite flat. So it's like a Paris 2A plus 2B lesions.
Yeah.
There's not much of a depressed area so far, no erosive area. So just by the white light appearance, it looks like a superficial.
Professor Honchi?
Yes.
Can we go for 1 minute only 1 minute?
Yes, yes.
Then we are coming back in 1 minute.
Of course, of course.
So I request Dr. Bimal to shift to Professor Nihos where he has completed. Shift to OT1. Professor, you are online, Nihos.
Yes. Yes, we almost finished. There, please show fluoroscopy.
Yeah.
Can you see that?
Yes.
There is still some stone. Look into the D2.
Yes.
We see all the nice fragments. So deflate the balloon. We just have one more sweep. So as you can see, here is still inflate. So and now we started from below. And as you can see now, the fragment is just below. Can you see below the endoscope? And now you can inject contrast to see, for those who don't believe, the cystic duct opening. Cystic duct is also clear.
Yes.
So, and I pull, as you can see, in the direction of the CBD, and the last stones came out.
Oh, amazing.
Okay, finished. Thank you.
That's a great demo, Professor Nahas, but I think your demo should be prefaced by a sort of a caveat we have in advertisement that please don't try this at home.
Thank you.
Thank you so much.
Yeah.
Can we go back to ESD case? Dr. Bimal, can we shift to Dr. Hatyavan case?
Well, I'll get rid of RDI.
Hanchi, you are online.
Here we go. No, that's the suction. I'll just make sure we haven't passed that lesion.
Professor Honchi, what are the method to assess the depth of invasion of these lesions? How we assess the depth of invasion of these lesions?
Yeah, so we were just.
And again, we just be very careful to make sure that we don't see any areas of dysplasia, any inflammation. Here you can see the vascular.
So you can see all these dots here. They are the papillary on the surface. So I think majority of us will be using the JES, the Japanese Esophageal Society classification, which looks into these vessels into type A and type B. So type A are essentially benign ones, so type B are the malignant ones. And for type B vessels, it's subdivided into 3 subtypes, type B1, B2, and B3. So the hallmark of changes of these IPCL would include 1, irregularity, 2, dilated, 3, variable in calibers, and also tortuosity. So basically you can see all these dots here. They are all in variable calibers, variable morphology. So this signifies that this is a neoplastic lesion, definitely. And it's confirmed on biopsy as well. And now when we look at the depth of invasion, we look whether there's still a loop-like formation of these little vessels. So you see how stable Dr. Hadawan's hands are. We're able to focus on individual vessels. You can still see loops there. So if the loops are there, it's B1. So B1 in Japanese classification, this is signifying a T1A, T1A, EP1, EP or LPM disease. So it means it's a T1A M1 disease. So it will be a good indication if you see lesions that has a preserved at least a B1 category. For B2 vessels, you lose the loop-like appearance. So it will be straight or somewhat non-loop appearance. And those will be signifying maybe already in the lamina propria or in the muscularis mucosae. And for B3, you see a very large vessel, almost green in color, because once it is large enough, it will somehow change color from brown to green. And it will be 3 times bigger than a B2 vessels. And those will signify a deep invasive cancer, and it is not an indication for ESD. So generally speaking, B1, B2, they are still okay. But of course, we also need to take into account of the circumferential extent. So if you go strict by say the Japanese guidelines, if you have a circumferential lesion more than 5 centimeters, so it's quite marginal whether or not you should do an ESD because of the risk of stricture afterwards. So what's your thought on the indication of endoscopic resection?
Yes. We think it probably in this case it's still suitable for perform the endoscopic resection.
Yeah, so the length is maybe just less than 5 centimeters. It's mostly B1 vessel, so we expect we have a high chance of achieving curative resection. So maybe a circumferential resection is still possible, but we need to be prepared for stricture. So we need to think about stricture prophylaxis after the ESD procedure.
Okay.
So what we do is we always have a very extensive examination of the entire lesion to make sure that all the parts have been examined. There's no area that we have suspicion of a deep invasive cancer. But essentially, you can see that most area here are just showing B1 vessels. So I'm still quite confident that this is a relatively superficial lesion that is suitable for ESD procedure.
You always need a zoom endoscopy before you perform a ESD in the esophagus?
Yes. So we always do a zoom endoscopy as much as I can in order to really have a detailed assessment.
Or do you prefer to use a black cap?
Yes, actually preferably if you have a black cap. So unfortunately at this time we don't have it yet. So the plastic cap that we're using somewhat has a stiffer cap, so it will somehow scrape off the mucosa, and you might see a little bit of bleeding that will obscure the view. So ideally, you would want a soft cap, and a black soft cap is the ideal diagnostic cap in my opinion. And so we also had some discussion whether or not you need a iodine chromo endoscopy, which is very, very traditional
diagnosis
procedure. So what's your thought on this case, Dr. Heidelman? Do you think you need it?
To be confirmed, yes, the standard still using the chromo endoscopy by using the iodide spray. But also there's some study that we can evaluate by using the RE and with the magnification as well. So probably we're quite sure about using this technique by using the RE and the magnification. And we look around and we still not seeing any invasive or meat-related lesions at all. So probably in this case, we have some confidence about using the IE, which now I'm using the magnification scope from Fujifilm, and now we're using the BRI IE with the magnification. So probably this case is still not have contraindication for ESD.
So
Yeah.
personally, I feel that the iodine is best used for determining the margins because sometimes just the digital image enhancement can have some confusion. Because you see some irregular vessels, you don't know which is the end of the lesion, then the iodine will help. But problem with the iodine is it actually induces chemical esophagitis. So once you spray on the mucosa, you see contractions, very frequent contractions.
Yes.
So during ESD, you really don't want the esophagus to contract too much. So in my practice, I do it more selective nowadays. If I have some uncertainty on the margin, then I would probably spray iodine. But if I'm very certain, as in this case, this is quite certain, then maybe I don't need to use iodine to spray before performing the ESD procedure.
What are the other endoscopic finding apart from the abnormal IPCL that suggest a mucosal cancer?
So the overall morphology, say the Paris classification, might tell you some information. So it's traditionally thought that if you have a Paris 03 or 01, those are lesions that is not amenable for endoscopic resection because predictively it's very high chance that this will be a deep invasive cancer. And of course, if you see strictures, very obvious signs of deep invasion, then you will not proceed with an endoscopic resection. But at this moment, I still feel that the detailed assessment of the capillary pattern is perhaps the best modality to determine the depth of invasion. There's recently a trial which the Japanese published by Dr. Ishihara from Japanese, trying to look at EUS versus narrowband imaging with magnification and the accuracy. So what they found was that there is a degree of over-diagnosis or under-diagnosis if you add in an EUS around 7%. So the conclusion of that trial was that maybe you don't really need an EUS in every cases. So in our practice, we use it only selectively, EUS. If there's some area that may have some suspicion or you're really unsure, then maybe we'll supplement with a mini probe, EUS mini probe with the gel immersion technique. That will help a little bit, but we don't do it routinely with the EUS to assess the depth of invasion.
In presence of reflux esophagitis, do you find a difficulty in finding these lesions? Reflux esophagitis.
Yeah, you're right. So sometimes in severe inflammation, these lesions would appear more indistinct, and it's difficult to find, like to determine which is inflammation and which is cancer. But maybe in my locality, the reflux are confined to the lower esophagus, but the squames are actually much higher up in the mid-upper esophagus. So the location will tell you, and whether it's more likely inflammation or it's more likely actually a cancerous. But there are difficulties, for example, in achalasia patient, you sometimes do see inflammation here and there. But for my practice, if I see a big area of brownish discoloration,
Dr.
then it's
Saurabh?
more neoplastics.
We are going to for the lectures.
Yes.
And we are disconnecting the endoscopy in the hall B.
Sure.
No, you, Dr. Hatyawan, you are online. You are online. Please, you continue. You continue.
Okay, so we just want to take a look. Now, I think it's almost a conferential, I think, Professor. The question is on 9 o'clock here. What do you think, Professor? The 9 o'clock?
I think it's still neoplastic. So it's patchy. There might be some non-neoplastic area, but they're too patchy for you to preserve. So if you do an ESD, this will be a circumferential. Very unlikely you can preserve a strip.
Well, yeah.
In
It's very,
some
very
cases, if
short.
is there a strip of normal mucosa, I would preserve as much as I can. But in this case, I doubt if it's possible because the normal area is too small to be preserved. So if it's an ESD, it will be a circumferential, and it will need injectional steroid or systemic steroid afterwards to avoid stricture. I think so. We can. Are you
Yes.
happy?
Yes, sir.
Shall we put in GA? Yeah. Yeah, maybe we put a scope out.
Chairpersons and moderators.
Yes, sir.
Now invite the next set of chairpersons and moderators, Dr. Avnish Tiwari, Dr. D. Srinivasa, Dr. Sanjay Khanna.
And then we change the
Okay.
as well.
Chairpersons, Dr. Sanjay Banerjee, Dr. M.T. Noor, Dr. G.S. Lamba, Dr. Shriram Agarwal, and Dr. Shravan
So
Bora.
we are shifting to Professor Binmolar here. Dr. Bimal,
So this is actually
we can shift to Professor Binmolar till we are planning for the esophageal ESD. Dr. Bimal, please present the history for Professor Binmolar.
Yeah, we will try.
So our next case is a 54-year-old female who presented with melena on 28th Feb 2024, single episode, followed by on and off non-bloody vomiting with drop of hemoglobin from 10 to 7. Upper GI endoscopy done elsewhere. It shows a 3 into 2 centimeter pedunculated polyp with broad base on the posterior wall of D1 with overlying ulcer. ESD was done there only. CT revealed an enhancing duodenal polyp of size 3.2 into 1.1 centimeter. And the plan is endoloop application and polypectomy. Over to you, sir. Dr. Binmoiler.
Well, such an interesting case. I'm just surprised not to hear anything about endoscopic ultrasound. Was an endoscopic ultrasound not done in this case?
Not done, sir.
I see. Well, I guess that probably would be where I would start, is first with an endoscopic ultrasound to better characterize this lesion. It looks like a subepithelial lesion. This is a double channel scope. You saw it used yesterday for removal of the leiomyoma in the sigmoid colon. I'm going to use it again. I think the double channel scope is vastly underutilized and underappreciated. Hence, it's really a pleasure for me to be able to emphasize its value in endoscopy. I think everyone should have a double channel scope. Now, there are many things you can do, obviously, without having a double channel, but it really is just giving you that additional channel. The only drawback of a double channel is it does have a wider diameter. So let's take a look at the lesion first. And there it is. And it looks like it's basically pedunculated. Just based on the appearance, the morphology, I bet this is probably a lipoma. So my bet would be, if we had a mini probe here, I don't think we do, mini probe, EUS mini probe. We have one in our unit. I use it all the time. The mini probe is no different than a catheter. Put it down, and then instantaneously, you don't have to have an echo endoscope, right? A dedicated echo endoscope. You can just put the mini probe down your working channel and switch on the ultrasound, and then you'll see this is probably going to be an echogenic lesion. And then you have your diagnosis. Now, if it's an echogenic lesion, it looks like a lipoma, the only reason to remove it is if the patient's symptomatic, and this patient had a bleed. And these lipomas very often bleed. They can get very long. Look at this one. It's like a cigar in the bulb extending down to the second portion, but it probably also flips out into the antrum as well. It probably pendles between both the duodenum and the antrum. So I think this is where the attachment is, the broad base. Now, how do you treat such a lesion? And I think we'll just bypass or skip doing the endoscopic ultrasound because we'd have to bring the ultrasound. We don't have it in the room right now. So let's just go ahead and assume this is likely a lipoma. Well, how would you remove this? Well, there are different ways you could do this. One option you could do is just throw a snare over it, bring it to the base, and just cut it off. And I think that's very acceptable. But one thing to remember is that lipomas are very vascular. They bleed very easily. You don't think of lipomas as vascular, but they are. Whenever I remove lesions on the IC valve in the colon, I tell the nurses, be prepared with the coag grasper, with Purostat, everything, because these bleed because of the fatty tissue in the IC valve. So one thing you could do then is you could inject epinephrine into the stalk, the base. It's very broad based. And the epinephrine will do two things. It will constrict the blood vessels, but it also will shrink the pedicle itself. So that would be a good option. So, that would be certainly very reasonable to do. Now, because I have the opportunity of being here with you in Delhi, it's a chance for me to show you what I call incremental innovations. So these are innovations that are not disruptive. It's not like Axios, which I think really was disruptive in that it enabled us to do things we couldn't do before. But incremental innovations are basically just better mousetraps. It's improving devices that we already have, that we're already using, but they have limitations. Now, one of the devices that I also really love is an endoloop. And I got to show you that yesterday, but it's an opportunity for me to show you what I think is an improvement, because I'm still amazed that after decades, we still have only one endoloop. Imagine we only had one clip still, but today we have a variety of different clips. Clips have evolved enormously. We have clips that have longer distances between the prongs. We have clips with different kinds of teeth, right? So Boston Scientific has the Mantis clip. It has like a hook on the end, and you can grab, and the idea is you close it, and that hook digs into the tissue, and then you open it up again. Then you go to the opposite side when you're closing a defect, and then you hook this opposite jaw, the prong, into the tissue, and then you deploy it. That's an improvement. And then there's the DAT clip, dual action tissue clip from Microtech, which I use routinely in my practice in San Francisco. This is an amazing clip because what it does is it allows you to independently grab each of the margins. So it's like the twin grasper. So there's a post in the middle, and you open up the prong on one side, grab the edge, and then you close that, right? So you've got the one edge, let's say the distal end, and they are color coded. There's a gold and a silver, so you can differentiate. And on the handle, you can close the prongs relative to the post, independent of one another. Then you go to the opposite side, you open up the other prong against the post in the middle, and then you bring the two together. So these are all improvements, incremental innovations of the basic clip. But we haven't seen this happen with loops. And so I'd like to see this happen. So I have one idea for an improvement of the loop. So here you can see this loop. And so it gives me a chance to kind of show you how this looks. So Ashwani is with me on my right, just like yesterday. And today I have Assis on my left side. I've got a double channel scope. He's not going to do anything right now. But Ashwani, you can see that you can pull if you pull the sheath back, what it does is it opens up the loop, and the loop is mounted on a snare. And that's what gives the loop stiffness. There are little lugs on there that I created that mount the loop on the snare. Now the loop will snap off of the snare afterwards, but the snare is very stiff. So Ashwani, why don't you just show how you can open up in the stomach just to demonstrate for you. So go ahead and open up. So here you can see nicely how this loop is mounted on the snare, right? It looks like they're tied together. They are. There are little lugs there. There are little snap-on. It's a snap-on. And it is attached to the snare. So the snare is a scaffold that holds the loop nice and open. So it gives it the stiffness. The problem with the loop is the floppiness. It just flops all over the place. And then when you try to close, the tip usually flips up, and then you end up not being able to close over the lesion. So this is one potential solution. Yesterday, you heard about, this is from Dr. Puri, his idea about a loop with a nitinol wire inside. I thought of that idea too. The problem with that is that if you have wire, you can't cut through wire, but also there's the risk that you can conduct if for any reason there is a disruption of the coating, the plastic coating of the loop. The wire's on the inside in the core, so there's the potential if you're going to, for example, snare above the loop and the diathermy gets to that inner core, the nitinol, then you're going to extend the diathermy to the deeper layer. And that will not be good. So that's the reason why I personally abandoned the idea of stiffening a loop with an inner wire. But it's a wonderful idea. I just don't know whether it's actually something that'll work. But these are exactly the kinds of ideas that I want everyone in the audience to be thinking about when you're doing these procedures. When you do a procedure and you have this loop that's flopping around, think about, well, how can we make this loop better? How can we make it easier? How can we make it safer for the patient? All right, so now you can see how the loop opens, and I'm going to have you now just close it. You're just advancing the sheath forward. So that's just pulling it in to the sheath, right? This comes in like that. All right. Now, the other device that I want to show you is on the left channel. Now, there's no need to use double channel for this. And in fact, this was designed to enable you to do it just with a single channel, but it's a helix. I'm going to show it to you on the inside, and potentially we could just do everything through one channel. You want me to show it one channel? Dr. Puri told me that I have lots of time. Rajesh, is that still correct? Do I have lots of time to show you? That way I can show you all variations. What you need to understand is that we have a toolbox. We have different ways of doing things. There's no correct way. It needs to be customized for each patient. Sometimes you don't have a double channel, so you need to do the procedure with a single channel. So you need to have different ways of doing it. A double channel is really great because so this is an anchor, it's a helix, and it allows me to anchor. And one of the things I think we are lacking are anchors. Now, you saw yesterday the 3-pronged anchor from Ovesco. Now, it was not designed as an anchor. It was, yes, as an anchor, but it was really designed to enable closure of defects where you could go in and catch the tissue deeply and pull it in. But the problem with that 3-pronged anchor, it looks a little medieval, a bit barbaric. You're a little scared because those spikes turn upwards. And you saw yesterday how some of those spikes already had gone through the lesion on the mucosal side of that leiomyoma. So I don't think that 3-pronged anchor is, in its current form, is the ideal way of doing it. Rajesh just walked in. Do I have time? 15 minutes is okay. 15 minutes. You said an hour before. No, that's fine. Okay. So we'll just stay with this. So I just want to show the audience all the different options. So this is a helix that's tied to a suture. And the whole idea is that you deploy the helix. You know the helix already from Apollo. There is a helix that is used. You saw the ESG yesterday, right? Maybe even today, I don't know. But you use the helix to pull the tissue. And then you get a pleat of tissue, and then you throw your needle across that tissue, right? So you have the anchor exchange catheter, and you throw the needle driver goes through, then you catch the tip and you throw the needle basically back and forth. So that helix is kept inside the working channel, but you can't actually just, remove, you can't detach the suture from the handle. So this is just a modification that allows you to detach the suture from the handle. That's all. So let's go ahead and we'll just stick now with the double channel to show you, but you could do this also with a single channel because you can deploy the helix and then you can pull out, you have the suture in the working channel, and then you open up your, maybe we'll do it just with this scope. I can do it in 15 minutes. All right, let's do it. Okay. Because everyone doesn't have a double channel scope, even though I think everyone should. All right, so now we're going to go through our bigger channel here. Okay. So now you pretend this is a single channel scope. It needs to be a therapeutic scope, of course. You don't want to be doing this with a diagnostic scope, like the 1T. And so here's our helix. There it is. You can see inside the helix is at the very tip. You see it there? The coil, it's just a helix. Nothing fancy, very simple. Simplicity is always virtue. All right, so now I'm just going to go inside. Patient's waking up a little bit here, needs a little bit more. Let's give some of that Buscopan now too. Okay, all right, here's our lesion, a lipoma. So let me just show you how we can deploy this. Well, we'll wait for her to calm down. We want the patient to be comfortable. Is this propofol we're doing? Now propofol, good. All right, you can see she's talking to us. All right, so now what I'm going to do, so here, if you can have the camera also show what Assis is doing, okay? So wait, I'm going to tell you in just a moment. The first thing is just to kind of, we got to get her a little sedated though. Patient safety always first. And you never do a procedure with the patient moving. And so your anesthesiologist is your best friend. And anesthesiologists, by the way, never get the credit they deserve. They're the ones who keep our procedure safe. And back when I was in Germany, I was giving the propofol myself. And I can tell you today, that's inconceivable to me, that the endoscopist would be doing the anesthesia at the same time as doing endoscopy. That's crazy. And I also, as you know, USA is a very litigious society. So I'm also very happy that if there ever were a lawsuit, and most of the lawsuits are related to sedation, not to our procedure, thank God I'm not involved. It's the anesthesiologist I can point the finger to. So they have a lot of responsibility on their shoulders. So thank you. What's your name? Pankaj? Pankaji? Pankaji is our hero here. He's made the patient sedated. All right, now I'm going to push in now, and then I'm just going to rest this up against this like this, just gently. All right. Assis, I want you now, you're going to advance this forward. All right, good. Just advance it. And now you're going to turn here. Okay. Slowly turn, slowly. You want to drive it in, slowly, torquing. It's going to dig into the tissue. All right. Now it's already starting to twist the tissue a little bit, like that. And that may be actually enough. Okay. Why don't we stop now? And now all you do is you pull back. Pull back, and it dislodges it. Okay? Okay? What happened here? Where's the suture? All right, let me go inside and see. I don't know what happened. Let me look. There's supposed to be the suture that I'm pulling out. Well, folks, let me just pull this out and see what happened. I don't know. Maybe it somehow mal-deployed, or is there an anchor on there? Yeah, it didn't, for some reason, it didn't fire. For some reason, did you pull it all the way back before? Oh, you just give me another one. There's another one there. It's okay. So these are all in sort of their first stage of development. I won't call them prototypes really, but these are sort of, they've already been thoroughly tested, and I've used these extensively in animals. So let's give this another shot. Can you explain what are you planning to do? I'm going to retract this, and then I'm going to put the loop over the base, over the suture, retract it, and then I'm going to deploy the loop at the base. Okay, let's just try this one more time. I have to speed up since my hour became 15 minutes suddenly. Okay, can you hold the scope here like this? All right, so let's just give this another try. All right, so I'm up against here. Advance forward, please. Okay, start to rotate, please. I think what happened is it dislodged from the tissue, because, a lipoma is very, very soft, and it's kind of hard to engage a lipoma. That's I think, if this were a GIST, stromal cell tumor, no problem. Keep rotating because it's got to go a little bit deeper. I think that was the problem. It pulled out because I didn't go deep enough, or it's just hard for it to. So So I think it's in there now. Okay, good. And then stop. So let's try. So what you're doing now is you're pulling everything back. Pull this all the way back. And when it's fully back, okay. It's supposed to go click or something. And it's supposed to disengage. You can see how I'm able to retract like this. So the problem is, you can see, push it out, please. So I'm sorry. The problem is that I don't have a structure that's holding the loop firm enough for me to pull out to release the suture.
Dr. Binmola, can you hear us?
I'm sorry?
Can you hear us?
Yes, I can hear you.
Yeah. Is there any particular point in the polyp where you want to make this puncture, or it can be anywhere? Base or apex?
I'm just going to loop it now. No, it's really just to show you. And I'm unfortunately, I couldn't demonstrate it with this, but I will demonstrate it afterwards if we have time, just on the wall. Because it's very safe. It just is an anchor. All right, so let's just loop this now, because it's very easy to do just with the loop. But it just, you saw how with the anchor, I was able to pull it into the antrum, right? So I can't do that now, but we'll open up now the loop. So open. And what I'm going to need to do is to hook it enough so that I could get it around like this. Oh, I need you holding this, please. And I need to make sure I can swivel this all the way around it like this. And then now I'm going to pull back just a little bit. So this is where, you know, at the pylorus, your scope wants to fly back constantly. But I think this is, see how I got a nice stiffness? I think I'm at the base. Okay, I think I'm good. So now I want you to close, yes. So you're pushing that. So he's closing the snare, which has the loop on it. And I'm very angulated here, by the way. So this is where things get always a lot trickier when you have lots of angulation. Devices don't work as well then. All right, so now, is it done? Okay, now you're going to grab the thumb ring. You're going to pull it back, which is closing the loop now. Okay, so now the loop closes and it springs off of the snare, right? It detaches from the lugs of the snare. Okay, and once it's closed, now you're going to open the snare again, and then I just detach this and pull it off. And is the snare open? There it is. It's open. All right, good. Now I pull the snare back, close the snare. Just close the snare. So the snare served its purpose. There you go. So you have to remember that when you advance this forward, that closes the snare. You want to open the snare, you pull back. Okay, good. So now I can pull this back.
Dr. Binmola, does this
yes?
Does this come like this, or is some sort of a homemade arrangement which we did? The putting on the loop onto a snare.
Yes.
Is something which comes pre-made?
Yes, it's pre-made. It's not. I didn't make this beforehand. It's already manufactured. Yes. Can I have some water, please? Just there we go. Well, that's a great idea. You know what? I love it. See, this is innovation. Now you've done it and you can save on your snare. Use the same snare to cut through. Ah, beautiful. All right. Yeah, we're going to name this device after you. All right. So now this is a snare. And you're right. We already had the snare. You just hook it up to cautery and you could use it. All right. So this is where it would be nice. Can I have something, the rat tooth forceps? Do you have one here? Now, one of the things I'm going to have to change is this loop here at the end is too small. And I definitely need a larger, I'm going to recommend that they make a larger loop here. So, because I would like to be able to pull on this when I throw my snare over it. That's the ideal way to do it. But I just don't know. It's a little difficult because these graspers are so thick. Open. We have one that's a little thinner, but you can see it can be a little challenging to get it in there like that in the teeth. Close. Oh, see, I missed it. Open. And you could spend like an hour doing this. Close. Okay, think I got it. Okay, 1 second. And then it just has to pull in like this. Okay, so now that way I can just kind of pull that and just give a little bit of traction to look, and we'll hold this like that. See, I can pull it out like that. Just gives me a little bit. Now open up the snare. All right, and then we just sort of get this snare. Do you see how violacious it's become? It's really strangulated. You know, in theory, you could just leave this. And I tell you, in 2 weeks, it's gone. It will slough off. You know, that's the loop and let go method, which is just great. And by the way, sometimes I do this underwater too. So this is where you want to make sure that your snare is right above the loop. And so this is why I like having a little bit of traction there, so I can kind of test to see. Do you see that the snare is not completely over the left side at the top? So I can see, is the snare all the way open still for me? Open? Yeah, fully open, yeah. Let me see here. Open. Keep it open. Probably almost needed a little bit bigger. Okay, there we go. That's better. Just close the snare now for a moment. And let me see. The key is that you're not, we have enough stock, actually, we still have some stock. This is why if I had given traction and closed the loop, it would have been down there at the base. That's how I wanted to do it. But that's the reason for traction, which you could do with a single channel if that anchor had worked. So I'm above the loop now. You see the loop is very tight. And this loop was specifically had the engineers also designed the loop so it gives a better, it's called the slip knot. Olympus calls it the slip knot. They didn't know that by calling it the slip knot, they were telling the truth. It slips. We don't want it to zip. So mine is called the non-slip knot because I don't want it slipping. All right, so now I'm going to cut this through. Okay. So this is when you're cutting this through like this. This is where you want to make sure that you don't, and it's off. So now the loop was there just to sort of, I wasn't above the loop enough. It came off because I was too close to the loop. And that's another reason why I like to have the loop really at flush with the bowel wall so that when I do my resection, my cutting, I'm at least maybe, I'd say 5 to 10 millimeters above that, 5 millimeters above when I close. That way you don't risk catching the loop, which can make it difficult to cut through, but at least you can cut through if you needed to. But also it just gives you, the ability to keep the loop in place after you cut. Because you don't know, there could be a vessel in there that suddenly starts bleeding on you. All right, so now this is the base of the area here. And so now the next question, I think, is what do we do about this base? Should we clip it? And I would say yes. I think we should just throw a clip. The best would be a nice wide pronged one, like a 20. There's now a 20 millimeter clip. So a nice big clip. I don't know if we have those. Those are great. But we just throw a
this clip is to prevent prophylactic for bleeding, or you want the remnant to fall off?
Only to prophylact bleeding. That's all. That's why if the loop had worked and the loop were still in place, we'd be done. Right? We'd be done now because the loop is prophylacting against the bleeding. But since, I wasn't able to give traction and get the loop flush up against the wall, I unfortunately don't have the loop now protecting against future bleeding. So let's see if, what's this here now? This is, okay. So let me get rid of, I'm sorry, just open up I have to get rid of this. Forgot about this one. Actually, I could maybe pull this out. Yeah, there we go. Okay, good. All right, take this. And we pull this out and give me a clip. All right, now if Rajesh gives me just a few more minutes after I put the clip on, I can maybe show you how well the anchor. So the problem, it's interesting. I didn't realize that the anchor limitation is, what would have been even a better idea is through the double channel scope. I could have done this. I could have put a snare to catch the lipoma and pull it in. I should have done that. I realize that now. I could have caught the lipoma and I could have pulled it back and given traction just with a snare. You don't have to actually dig something into it, but the helix anchor was designed by, my thought was I want to be able to remove stromal cell tumors, cysts and leiomyomas, and I want to invert the wall. And then I can get a serosa to serosa apposition. And then I can either let it just slough off and enucleate, like yesterday you saw. And first I would do a cruciate incision to facilitate the enucleation. That's just, you need to open the mucosa up, right? So that the underlying capsule and just can enucleate. Or you can just go above the loop and cut it or ESD it. There are different ways to do it. You could put a snare right above it and cut it. That'd be very fast. Or what'd be very easy is just use an ESD knife, a dissecting knife, and just dissect above the loop. That'd be the other way to do it. So good. All right. Now here's the clip. What kind of clip is this? 16? Okay. So let's see if we can do this. Might be a little bit tangential, and the stalk's a little floppy, but let me get into position. This is, by the way, if you work in the bulb, you have to have a cap on. Otherwise, there's just no way. Even with a cap, it tends to flop back and forth. So the best way to do this is if I can get my assistant to help turn. He'll be cursing me in a moment, but I'm going to try to turn like this, okay? And then you hold it, turn, please. All right, let me see if I can do this. And sometimes it works and sometimes it doesn't work. Okay, here, open the clip now. And then we want to get it just really flat as possible. The reason is it's coming out at 6 o'clock. It would have been really hard to do it the other way. And maybe it'll work. And now hold that. My assistant is my hero. Okay. And suck in, it'll close. Just close it now. I sucked it in. Close. Did you close? Okay, just hold it there. Close. Don't deploy yet. I want to look and see whether I actually got it. We can. Oh, it looks great. Deploy. Yeah, deploy. Good. All right. Okay. See, everything is harder. Look, even the clip is hard to come off because of and there it came off. So when you're sharply angulated with your scope, you have to realize things are more difficult. Look, the reason why I know this so well is our biggest struggle back in the Axios development days with Exlumina is every time we had the echo endoscope very angulated, we had all sorts of problems with our sheath, and the Axios would start to already deploy prematurely when we're pushing against resistance. And that's why it's so important never to push against resistance when you're doing an Axios procedure. So there we've got it. We can flush this off a little bit. And now if I have any remaining time, let me see if I can get the anchor. Can you just go in the room next door and grab another one of the anchors? Or just give me the anchor there, because I think the anchor still works. And, now that I'm thinking about this, we've done the job. And in a way, I sort of feel that to put an anchor in now is not necessary. And it's, so I think we'll just stop here because there's not an indication that I can justify, even as much as I'd love to show you and as much as I also would like to see, but I actually can't really justify doing it. First, do no harm, right? That's the motto of our practice. So there it is. And now I just get my specimen and I'll put my money on this, that it's a lipoma. So we'll just suck that up into the cap. Hopefully it'll come. Otherwise we have to get a Rothnet, but I'll just slowly pull this out.
Thank you, Professor.
Right, it's coming. Often you lose it right at the cricopharynx. One time it actually fell down in the trachea. So we don't want that to happen. Okay. 1 second. Not yet. You got it. Okay. And there it is. Look at it. There it is. There's our lesion. So I think it's, clearly we got the whole lesion, so it's all good. And there it is. And just flip it over to the other side. So at least you know, what's important in endoscopy, it's the process. It's not really so much where the pedicle was, you see? It's not so much what you're doing, it's about the way that you problem solve. And
Thank you,
this is why
Professor.
we need really a treasure chest of devices, you know, and
Thank you, Professor.
toys that we can reach to and assist us customized, individualized to each patient.
Am I audible? Thank you, Professor, for a nice demonstration. Now we are shifting to OT3. Dr. Hathawan, over to you.
We have put the patient under general anesthesia, and we've just already done the marking. So now we're going to put the cap on. So this is the conical cap from the Fujifilm. So this is the ST hood. So because we had the discussion just now on how we will do a circumferential ESD, so that I think both of us agree that a tunnel technique would probably be the best if you are doing a circumferential ESD. So in a tunnel procedure, I guess the ST hood will definitely give some help
benefit, yes.
in terms of getting into the submucosal plane. So once the cap is being mounted, then we will put a scope in and start the injection procedure. So can you explain what's your plan of the ESD for this particular circumferential lesion?
Yes, sir. So we are planning to perform the 2 tunnels.
Yeah.
One is in the anterior and other in the posterior. Now we already finished the marking in the proximal margin and also distal margin, which we will show you in a second. And then after that, we will perform in the distal mucosal incision. And then after that, we will move our scope back to the proximal and start our mucosal incision. So what I'm using right now, this is the Fujifilm scope. This is a therapeutic one, 760 CT, which connecting to the cylindrical cap from Fujifilm as well. And okay, I think we are ready to perform the mucosal incision first.
So unfortunately, this case has a circumferential involvement, but in case there is a strip of normal mucosa that can be preserved or remaining, I think generally speaking, we would like to preserve as much as possible. Personally, if I can preserve, then I would start the incision first at the site of the preservation of the bridge, because occasionally if you already started the incision elsewhere, it will make the subsequent incision that may hurt into the preservation of the bridge. So I would start with the bridge. But this case, it's a circumferential disease. So I guess what we'll do is start to create the tunnel opening and the exit based on the location.
So we would like to show you the marking. Okay, in the first we use the BRI, so it can demonstrate us the demarcating line here and here. And then we a little bit pull back and marking in the proximal margin. Also, we move our scope to the distal part. Still, we can identify the demarcation line as well by using the BRI, and then we marking in the distal end. This will be our distal margin. So this is a circumferential lesion. So we have to perform the circumferential marking as well for the both proximal site and the distal site. Okay, and next we're going to start the submucosal injection. Okay. Needle. So I think by using your eye can give us a nice view of the demarcation line as well.
So the patient is placed in the left lateral position. So we always bear in mind where gravity is when we are planning any ESD. So in esophageal ESD, so usual the standard position is a left lateral So we know that the left wall will be the dependent end. So when we're detaching the final bit, it's important that we have to dissect the left wall first. Otherwise, everything will fall onto the left wall and makes the final excision difficult. And we will also think of ways that will help to maintain the view, like tunnel technique, and also maybe some traction techniques that we may have to use in the subsequent procedure, like the dental floss with clips or other clipping devices that will help to maintain attraction. But in a circumferential lesion, I think a tunnel technique is the best initial technique to go for in order to obtain a good submucosal view.
Okay. So I'm ready. Yes, needle out. Okay.
Where exactly do you start making the tunnel? Is there any choice?
So I think we had a discussion just now. We are planning to do an anterior and posterior tunnel.
Okay. Yeah,
And then
injection.
connect.
Dr. Hongchi,
Yes.
can we take the room for 1 minute?
Yes, of course.
Okay.
Please, please.
Professor Binmuller, you are on the line.
Okay.
Ex vivo to show you. So
Yeah.
it works very nicely ex vivo, but you can see the helix anchor.
Focus here. Focus.
So here on endoscopically, you can see the helix anchor there. You can see the snare. And then what I did is I opened the snare a little bit. As soon as I was out with the suture, opened the snare a little bit, fed the snare over the suture. And then this is mimicking a subepithelial lesion here. We're obviously not going to give any cautery here because your finger's in the back there, but it's just showing you how now here I can give traction here. So this is my ability to give traction. So that would be the mechanism, or I'll just pull back a little bit so that you can see this here. How, let me just take the snare, open this, snare's open, yeah. So here you can see how this helix traction device is able to allow us to do this without a double channel scope. That's just what I wanted to show you. All right.
So
okay, great.
thank
you.
you, Professor Binmuller. Thank you for the excellent demonstration.
Professor.
We go to Professor Katyan room where she is going with an ESD.
Hello.
Hello. You are online.
Thank you. So we are continuing the injection now. So the key of injection in ESD, so is to, after the first injection, you try to do the injection on the edge of the bleb that you create.
Yeah.
And then
Injection
it will
okay.
spread onto the,
Thank you.
the adjacent mucosa where you want. And it will help to avoid an injection that will go too deep into the muscle layer. So because the bleb that you already created will help you. And it's more like a dynamic injection. So you will see
Needle
how
out.
Dr. Hadawan, once he stick the needle in, she will retract the needle back
Hang on.
just to make sure that the injection will
injection.
elevate the mucosa
Injection.
and make it
Injection.
into the submucosa, but
Injection.
not going too
Okay.
deep. And you
Thank
can see that when you withdraw the needle, the
needle
bleb
back.
that creates will come towards yours. It will come towards you. That will help you to identify whether the bleb has been enough for the dissection. And the esophagus is rather narrow area, so the injection has to be a little bit more tactful, because if you inject too generously everywhere, it will just bulge into the mucosa, and then the lumen will become so small and it will be difficult to visualize the site of your incision. So you just inject enough for the elevation, but not excessively, so that too much of a bleb has been created. And then you inject multiple areas until you can have a circumferential area for injection. And sometimes you may even try to inject just maybe 2/3 or 1/3 of it, and then add injection as you need it, because nowadays all the knives comes with an injection channel, and you can just inject through the knife. And that will help you to maintain the view within the lumen of a narrow esophagus.
Okay,
as in
needle
this
out.
case.
Thank you. Pull back a little bit.
So
Okay, I'm ready to go.
Pull back the needle so that the injection would not go too deep.
Injection, please. Very good. Thank you. Not too much. Okay, enough. Okay, needle out. Thank you. Okay, needle out. Yes.
So what solution are we using for the current case?
This can be used as gelofuscin
Gelofuscin with
with
acrylic
small amount indigo calamine and small amounts of adrenaline.
adrenaline. So do you
Yes.
prefer adrenaline in esophageal procedures?
Most of the case, in Thailand we use glycerol.
Glycerol, but also
Glycerol.
epinephrine with
Yes, yes, yes.
because I'm a little bit hesitant to use adrenaline in the esophagus because the esophagus has a direct close communication to the heart. So if any fluid leaks out, it may really get severe tachycardia. And
Yes.
also, because the esophagus has a direct venous drainage, not through the portal venous system, but through the systemic system. So I'm also a bit hesitant because it may actually make the adrenaline effect more aggressive in the systemic circulation.
Okay.
So, but I don't think there's
Injection,
any
Rachel?
evidence. But if you're doing a
Okay,
POEM
thank
procedure,
you.
then definitely don't add any adrenaline because
Okay, Al.
once you open up the muscle, the adrenaline will spread out, and it's very
Okay.
dangerous in that.
Okay, it's true, it's true.
Yeah, but in ESD maybe
A little bit maybe
yeah,
safe
maybe
for us
it's a
to
bit-
dissection because sometimes bleeding is really difficult for us as well.
So for gastric, then I usually use the epinephrine. So we've just completed a randomized
around,
trial that showed that epinephrine used in gastric ESD can actually make the procedure faster. So it's our practice that we use gastric ESD. We
Okay.
add epinephrine.
Hold on.
What dilution of norepinephrine are you using in this patient?
Sorry,
Can you hear me? What dilution of norepinephrine you are using in this?
Injection, please.
What concentration
Okay.
of epinephrine are you using?
At least, neither end. At least must be more than 1 per 10,000.
1 per 10,000?
More than that,
How much you mix into a?
We mix a little bit of like 0.5 to the 200
0.5 mil.
mil.
200. Oh, that's a very low concentration.
Yeah, we use a quite low concentration in the esophagus.
I see.
Yeah. Okay, so what do you think, Professor? We
Yeah, it's good.
finish.
Yeah. I think you can start incision and add if you need. This part may be not so injected, but I think you can supplement it later.
Later.
Yeah.
So we will
Start here. Yeah.
here first, and then later we supplement the
Yes.
fluid, and then goes to the anterior.
So for distal incision, I think it's important that you go deep into the surface of the muscle because that's where you exit the tunnel. And if it's very shallow, occasionally you will miss the exit, and then you just go beyond the incision and outside beneath the incision that you made. So if you make it deep enough, then it will be much easier for you to visualize the tunnel exit when you are dissecting. And as with any other ESD, generally speaking, the procedure needs to go into the deep submucosal space. So maybe like a deeper 1/3 above the muscle layer. Of course, it's not like POEM where you already go right on the muscle layer because you will cut it anyway. But you still hope to maintain roughly around like 1 mm above the muscle layer.
Are you comfortable doing this procedure if your patient is on aspirin or clopidogrel?
For my practice, I don't stop aspirin, but I know many Japanese experts, they do have a concern with aspirin and they would stop it. But in my cases, I don't stop aspirin, but clopidogrel, I will stop it. So maybe 5 days of clopidogrel, I will stop it. Aspirin, I will keep it. All the other anticoagulants, I will stop it.
Do you insist endotracheal intubation in all patients irrespective of the size of the lesion?
Sorry?
Do you insist endotracheal intubation in all patients irrespective of the size of the lesion?
That's an excellent question. In my practice, for esophageal, I prefer doing it in general anesthesia. There are a few reasons because, first of all, most of the time our ESD procedure will take at least half an hour or more, or maybe sometimes even extend beyond an hour. So if I have to handle both sedation of the patient plus the ESD procedure, it's pretty hard. And also, if I use techniques like underwater procedure in the esophagus, then obviously there's a risk of aspiration. So if I put the patient under general anesthesia, and if the patient's risk is not high, I think it's a good practice, especially when I'm teaching a junior. He may struggle a lot with if the patient starts choking or if the patient starts gagging, then it's really not ideal. So but I know like it's really institutional practice. If you're working in Japan, somehow the Japanese doctors the Japanese patients are super obedient, so they never move. But the cases that I saw in Japan, the patient never moved. But in my center, when I see patients, even on the diagnostic OGD, the gags, they do a lot of movement. So I guess it's like situation dependent and where you're working at, stuff like that.
I think the cap is quite far.
So you can see that there's already a incision that made deep enough into the superficial submucosal space. You can see the blue color here. So all you need is to extend the incision hopefully around the lesion, the marking, so that you connect into a circumferential incision. So the conical cap is good to get into the space, but sometimes the cap actually narrows your space in the sense that it makes the knife a bit long that to come out, and the dissection could get tricky at times, especially when you're doing just mucosal incision but not trying to get inside the pop head or tunnel. So that's a limitation. So you may need to adapt to situations and choose the better option. Esophageal ESD, personally, I think just a straight cap can also do most of the work. But a conical cap will definitely get into the space in the submucosa easier than a straight cap.
Okay. That's too far. This one is marking too far, I think.
Yeah, I think you should follow the mark
Yeah.
on the right side. Yeah. Yeah, you see the mark there on the right side, 2 marks there.
Yeah.
So you just join those. Yeah.
And then I move here.
So in the esophagus, the ESD motion is almost like a rotational motion where you try and use the torquing of your scope together with some up, down, and left, right. So you torque and turn and swing the scope towards the side where you want to incise. But of course, there are some situations like on the left wall, it's more risky because if you do swing the scope like that, there could be a time when you incise a little bit too deep. So so that's why we choose this shorter knife in order to maintain like a safe incision, not going too deep into the muscle on the surface of the muscle layer. And also the bleeding actually occurs mostly in the mucosal incision. because the vessels runs longitudinally in the submucosa. So when you perform an incision like this, you actually will encounter these strict vessels. So preferably you want to cut shallow in the initial cut with the endocut mode. But then once you see the submucosal space, you use coagulation mode to kind of mix a coagulation current with a cutting current that will help you to also control the vessels that is situated in the deeper part of the submucosa until you see the surface of the muscle. And so I think this is what Dr. Hadawan is trying to do. He's already trying to coagulate the deeper vessels with the current device. So are there any questions from the audience or about the case?
Yeah. Coagulation. Mm. Okay.
Can I ask a question?
Yes, yes.
So do you make multiple tunnels since this is circumferential? Would you make multiple tunnels, maybe each about a third of the circumference and then connect the tunnels? Or do you plan on using clip line for traction to lift up and then dissect? What's the strategy that you prefer?
So we had a discussion just now, so you made a good point. So if it's non-circumferential, I usually use a clip line. But since this is a circumferential, I prefer a multi-tunnel technique. So maybe a third on anterior wall, a third on posterior wall, and then I'll connect on the left wall first, because the left wall is where the dependent area is, and everything will fall down on that side. So in that situation, you might encounter some difficulty when you're connecting, and then I may add a clip line at that point in case I run into some difficulty in providing the traction. And finally, everything will fall down from the right wall. So I will dissect the right side wall at the last bit. So that will be my own preference if I'm doing a circumferential ESDs. I think clip line traction is a very handy technique because essentially a very low cost. All you need a clip, all you need is some dental
Could I have
floss or
injection
a
a little bit?
suture material. And in non-circumferential situation, I use it quite often. I basically use it liberally. Whenever I find it, the view is somewhat not so good, I wouldn't jeopardize the view by struggling and to get in. I'll just clip in line and pull it up and continue the dissection with the clip line.
Is your plan to do a circumferential incision at the upper margin now, or are you just going to do that third to make your tunnel and then continue along the circumference?
So what we're planning, I think we're planning a circumferential distal incision because anyway, it won't affect anything. So because in that case, wherever you go in the tunnel, you know where to exit. If you already have a circumferential distal tunnel opening being created, and I don't think it would affect the injection or the elevation of the submucosal plane, even if you open a circumferential incision in the distal end. For the proximal end, we usually open it smaller so that you can get in easier and maintain the view within the submucosal tunnel.
Okay. Okay, need hang on. Yes. Okay. Yes. Thank you. Okay. Minaren.
Sure.
Neither out.
You want to try putting the cap on? Let's see.
Yeah, well, let's just
Okay, neither out.
opposite to the needle. Yeah.
Okay.
Just sort of let me know. Or just try it at home.
Yeah.
Yeah.
Fine. You don't have to do it here.
Okay, thank you. Okay, neither
Yeah,
in.
keep on air first and then later.
That's good.
Yeah.
We can do little.
Okay, knifed. Got to compress first.
We're making deeper into it.
Yes, yes, this one.
What do you think?
Actually, I understand that Martin, this program are this.
Yeah, now it's distal, and then we start making small and proximal, and then tunnel. Tunnel.
Okay, neither in. Okay. Okay. Maybe a little bit injection. Sorry. Needle, please.
Or actually, you can use the knife pump. To
Yeah,
inject,
yeah.
there's-
Almost, we almost
Yeah.
close.
Yes.
Okay. Hang on. Hang on. Okay. Okay, please. Injection. Okay. Needle in. Thank you. What do you think, Professor?
Yeah,
Is that right?
good. I think you can add some more injection with the knife if needed. But you just need maybe like 1 cm more of incision, then you will join the two, the circumference.
Okay. Out, please. Needle out. Oh, coax is not.
Last time. No.
Okay.
Yeah, so now it's the circumferential incision is made. A little bit of bleeding, but I think it could be controlled by the knife.
कैमरा लाओ ना नहीं वो तो लाओ कैमरा तो लाओ कैमरामैन नहीं है कोई नहीं उसको मेरे यहाँ लाओ उसको बोलो यहाँ से बंद करे उसी से
Am I audible in the hall?
Yes.
So can we conclude from endoscopic side because this case is going to take time and we are on time. Is that okay?
Yeah, I think that's okay.
So I just wanted to say because I'm in the endoscopy room and Professor Hanchi and Hatyan, we will do the rest of the case offline. And I'm thankful to everyone. I don't want to take anybody's name because it is very difficult. But the important people in my life who has helped me is Dr. Pramod Garg, Dr. Lamba, Dr. Monica, and many more people like Shri Hari. So that's why I'm not taking the name because I may forget. In my unit, I'm very thankful to Dr. Abhishek Khaturia, Dr. Jubin Dev, Dr. Bimal Sahu, and as I said, it's difficult. But a special thanks to Ravi Grover, he's always be a savior, and Maisha team who has worked very hard, all patients, all international delegates, and everybody who is a part of this conference, I would like to thank. I request Dr. Pramod Garg to conclude there because coming from here to there going to take 25 minutes and we will get late. So I'm sure Dr. Pramod Garg is there. He's going to give the closing remarks.
Yes, Dr.
And he will give the prize distribution to the winners. The check I'm going to sign once I will reach there, but at least the check can be given to them. So I request Dr. Pramod Garg to take over from that side. Thank you.
Thank you, Rajesh. Before we give the concluding remarks, we have the pleasure of announcing the results, which someone will do.
So first, I'll be announcing the results of the plenary session. So at third place, we have Dr. Nikhil Santalia. At the second place, we have Dr. Harshvardhan Tevatia. The first place, we have Dr. Shivam Khare. We now move on to the video digest contest. At third place, we have Dr. Saurav Mukhevar. I think he's not there, but Dr. Bhushan is there who presented on his behalf. Yeah. At second place, we have Dr. Ganesh CP. And at first place, we have Dr. Sahaj Rati.
Please give some concluding results.
So first of all, I'd like to thank all the faculty, both national, international, and the delegates who have come from far off places to attend this amazing conference. My heartfelt thanks to them. And I would give full compliments to Rajesh. He has done an amazing job, and the amount of effort he has put in is tremendous. So please give him a big hand. I don't know whether he's listening to us, but I'll convey that to him. Very good. So it's all Rajesh's job. I think this is perhaps the largest conference that that has been organized as an annual conference of SGI. And since he has raised the bar, I'm sure in future meetings also the standards will be maintained. In fact, the expectation may be exceeded there also. So also my thanks to all the educational partners who have actually supported the meeting to the fullest extent. Otherwise, meeting of this kind is not possible. And from Rajesh's side also, I give them all the credit for supporting this meeting. In addition, my thanks to the entire Medanta team and all the other people. For example, Savan, I was telling Savan that I feel that AIMS is organizing this conference because Savan is our own boy and he has been in this hall for 3 days. I thought AIMS is organizing. And so this tells you the team effort, that how a successful meeting can be organized with the participation of everybody. You take people along with you and you have success in your hands. And also my thanks to the Maisha team who have actually organized the conference very well, and the hotel staff and the audiovisual team who have done a tremendous job. So this morning we had a meeting and the American ASG people were saying that, look, we were so amazed at seeing the quality of the transmission. What have you done? So thanks to them for this wonderful program. Thank you all for staying back. Please join for lunch. Thank you.